Sir, you're charged with especially aggravated kidnapping. You're also charged with aggravated assault, and you're charged with theft of a firearm worth less than $2,500.
You're talking about stuff that is not relevant.
Hello and welcome to the Court of Public Opinion. I am the Recovery Addict, and boy do I have a case for you today.
Why is the dog chewing on this guy?
I think they have got the wrong guy there.
Got the wrong guy. The dog was biting him.
He roughened him up quite a bit. There's a lawsuit.
As the agent for Peyton Ansley, John Milton, you are indicating to me that you're quite familiar with Peyton Ansley, John Milton, and that's basically you. Is that correct?
I am the agent authorized to represent Peyton Ansley, John Milton, as written in all capital letters.
All right, and you understand for my purposes, that language doesn't make any sense. So
No, I do not.
I understand. Okay, well, I'm telling you that. And so I am, until you disabuse me of the motion, or the notion, I am inclined to believe that you are both the agent and the person. So, and it's in
I'm
all
not a
caps.
person. I am one of the people. Thank you.
Okay, thank you.
I'm not a person, I'm one of the people. Welcome to the Court of Public Opinion. I am the Recovery Addict. Thank you very much for joining me this afternoon. Where's my music? It's very loud in my ears. Is that better? Sorry to blast your eardrums out like that. My apologies. Welcome back. I have to brag on my wife just a little bit. Yesterday she made the most amazing batch of bread, and normal loaves of bread. We're talking like whole wheat bread, but just not whole wheat, I guess. It's just the delicious. She grinds her own flour, makes the bread. It was so delicious. But she also made she had extra dough, and so she made an artisan loaf, one of those like rounds. Oh my goodness! I ate like 2 wedges of that. You cut it like as a dessert and just eat it. Oh my goodness, it was so good. I ate that right after I fed the cat. Yes, I fed the cat, and Mrs. R.A. was off dropping my son off at work, so I thought I could get away with this. Like, quick, feed the cat. She won't know. It'll be good. I come in, I've got like empty tuna fish can in hand, and got deer in the headlights. She's like, so now I'm busted. Now I'm in trouble again because I'm feeding this cat. Somebody has to feed it, right? I don't know. Oh, no. Please tell me I didn't screw that up. Please tell me I didn't just screw up the entire recording for the Elijah McClain trial today. Which I did. Oh, man. Okay.
Don't miss the
I'll fix this afternoons, but I think I've messed up. All right, let's see where we are. Today, in the Maya case, in the Maya trial, as I'm looking on Zoom, I can see the lawyers are filing back into the courtroom. They're not quite ready yet. I think just some of the defense has shown up. But it's like we have a brand new judge. We have a brand new judge in this trial. He's cracking down. He's down to business. The humor is gone. And he wants to get this done. Really, it's a scheduling thing. That's his biggest issue. It's the amount of time we're wasting on these silly little arguments. You objecting to everything. It's like we refuse to let the other side score any points or win any argument without us fighting tooth and nail over it. He's like, this has to stop, guys. At some point, we just have to agree that the other side gets to put on a case.
I'm not a cat.
And make the objections where they count, where they matter, and don't just try to claw each other's eyes out over every single thing they do. So today the judge has sort of come down on both sides that way. And so we're seeing a little bit different behavior. We saw in Mr. Anderson that he completely said no questions to a witness, a big witness, very important witness, and said no questions. And it went to the jury. Jury had a ton of questions. Then he came back and got his cross in on the second time around, but it really threw her off. It's really surprising. DMB says, cat, when did he get a cat? I love cats. Show me the kitty cat. I demand furball. We did show the kitty cat briefly earlier. I can show you again. This is the cat that we're speaking of, and it has adopted our house and our kids, and I sort of have been feeding it. So I guess we have a cat now. We put a listing out on our little neighborhood little community page, trying to find the actual owners, because it has a collar, like one of those little flea collars, and and so we think it belongs to somebody, but we have just a ton of stray cats in the area. This one's nice. Kids absolutely love it, adore it. It's been sleeping on our deck. It sits on our chairs and waits for us. It is not happy when it's not let in the house. It comes and looks in the window and meows loudly and looks at us. But anyway, we don't know. We need a Pickles cam. We might have to do a cat cam. Although I'm pretty sure cats just won't participate. If we want them to do anything, they won't. Anyway, here we go. We've got, let's see, we've got a few things to do. Let me just check on court very quickly.
How does he do that?
There we go. There's where court's at, so that's all good. We're waiting on that. As soon as we hear audio from there, we will bring it to you. Let's see. The cat probably needs some care, and honestly, I've got a friend who owns. She's a vet, so she owns the company. I've done a little bit of work for them, and I might just say, hey, help me out a little bit. We don't think there's a chip. I run the cat through my metal detector, or I run my metal detector over the cat, and I haven't detected a chip. Now, if there's metal in the chip, which I think there is, if there's metal in the chip, it should be able to find it, because I can literally find the post, like the post of an earring, about 2 feet deep in a volleyball court with my metal detector. So I think I could find, just an inch away from the metal detector, I think I could find a chip in a cat. But anyway, this is how everyone who gets a cat gets a cat. And now I'm one of you, apparently. We're trying to find the people who actually have a cat. But anyway.
Scratch all that. Oh,
Vicky says, hi, everyone, coming from Rob Lawn Lumber. Wonderful. Rob is fantastic. We love him over here. He's obviously his legal mind is, in my opinion, second to none. We love the way he runs his channel as well. Enjoyed for quite a while his takes on many different trials. And the fact that he's covering this one and providing legal analysis as he does a wrap up and a summary of everything in the evenings is fantastic. It has seriously impacted my sleep schedule, and that's why I have these black circles under my eyes. But Lawn Lumber is wonderful. And appreciate him when he's able to join us in chat as well. And he said some great things about us on his show, which we are very grateful for. Rob is wonderful, and I'm super excited. If you didn't watch the end of his the outro video of his live last night, he showed the making of that pen that he made out of the pencils, which I think is really cool, and it was awesome. It looks beautiful. You've got to go back and watch that. If nothing else, you have to watch everything before then, but you have to watch that as well. All right. Last night is awesome, and there's more to come. He's got some more because he wasn't able to go over everything last night. Let's see, because he has a real job. Some of us get to sit here and play on the internet all day, but Rob actually works during the day and then does this in the evening, which I think is crazy. That's like correct? 2 jobs. And he manages to pull it off and still has time to make really cool pens. All right, let's see. We have, let's see, what do we have? Why is that not working? I'm so nervous about this. This is so okay. Today might be a loss on that other trial. The WebEx has been a nightmare. No chats on screen. That's a problem. Fun and funky. We'll get that fixed right now because we have to celebrate Kim R. Kim was first in chat this afternoon. First in chat wins a prize, but Kim knows that because she is a repeat offender. She has been first in chat many times. And so Kim has once again, by being first in chat, claimed rightful ownership of everything IP-related worldwide. So the internet is all yours, Kim. Keep it running for the rest of us today, and we will not complain very loudly. We might complain, but we won't complain very loudly. So thank you, Kim. Appreciate it. Good to see you first in chat again. Congratulations on that one. All right. Where are we on? It's time to put the GoPro and see if he has on the cat and see if he has a home. I don't think this cat would tolerate a GoPro very well. Let's see. I don't think it would tolerate that very well. It's a nice cat, but I guess I'm learning a lot about cats, you guys. cats do what they want when they want, and only if they want. There are times when cats will like come when you call them, and that's when you're feeding them. And then it's only if they like the food. I tried twice to feed the cat. First, I tried a different type of fish. Not a fan. It went back and it laid down, and I looked at it, and it looked away. I'm like, oh, so that's how we are. And so I tried. I do have an air tag. I put an air tag on his collar. That might work. We might do the air tag route. Anyway, I have a lot to learn about pets, and we have to figure out what to do to take care of the cat. The kids have wanted to name it something else anyway. All right, so that's neither here nor there. We're here to talk about the Maya trial, not about my sudden acquisition of cat. But anyway, I'm just hopeful that I live in an area where there are lots of fields nearby. There's lots of little wildlife in the form of creepy crawlies around here, and I want if we have an outdoor cat, which is what it would need to be a good hunter, where it would keep the little creepy crawlies from crawling in the house. To make stuff called cat food. DMB, I'm not sure if I'm ready to actually buy cat food, because that is a level of commitment that is just, it's beyond where I'm at right now. All right. I will tell you that as a dad and as someone who had a pet growing up, that watching my kids, watching them interact with a pet, there's something just good for the soul to see, your kids just playing nicely with the cat and just being caring and learning that and playing together. They've done it for like 3-4 days straight. That's all they've done all day long is just play with the cat. But what is a good camera for outdoors live stream to YouTube? Dr. Dreamy, what's your budget? I ask that because there are some very nice cameras that are waterproof that are going to be in the $5,000 range with a full pan tilt zoom, 40 power. You could mount it on top of your house and spy on the whole city. So there's some of those, and you can go cheaper as well. But it just depends if you're is it like a bird feeder cam or things like that. If it's protected from the elements, you can get a lot cheaper. But it has to be really protected because you don't want water to get in a non-waterproof camera. Okay. Let's see. Need to go get some cat food. Then I'm gonna need some kitty litter and yeah. Okay. Is Mrs. R.A. using cat time as science time for school? She is more allergic to cats than I am. I can pet a cat and wash my hands and be all right. But she cannot. If you pet a cat and walk by Mrs. R.A., her eyes will close from swelling. So this is why she's not a fan. Scratching post. I know we've got to get a little bed and everything. Traded 2 possums for Pickles the cat. Debbie, you have a deal, but you got to come and get him. The possums hopefully will run away. But all right, court here. Where we're at as far as the let's see. I need to rearrange that. Just 1 second here. It's coming in on 2. And we did downstream keyer. There we go. All right, so where we are in court right now as far as objections, that we're at 1,111 that we have counted. We know there have been a lot more than that, but that we have counted. These are times when we noticeably can tell that the other side has said something to the effect of, I object. Or whether say hearsay or whatever. If these objections are what we're counting, we're counting both sides, but we're only counting from basically opening statements on. We know there was a lot that happened before because there's 5 years of pre-trial litigation that has got us to this point with countless objections. We know there are like 52 rulings the judges made that, there's obviously some battles that came on. So we're just counting this. And we did a contest. We did a contest where you guys got to submit. We had about 981 people submit their guesses as to just how many objections there would be. So, at the very beginning, the low end, we were in the 800s, and I think I can just let it play. Let's see. There we go. We can let it play for a while we're waiting for court to begin so you can see where your guess was and who we've passed. Just using a little teleprompter to run this. scaled down and floating over me, but that's the best way I could get it on screen at this time. Okay, haven't watched it all, but I'll guess 4,344. DMB, you would be the second highest guess. Well, no, fourth highest guest. We have 2 in the 5 digits. We have 1 of infinity, and you would be the next highest. So I think you're a little high, or at least everyone else thinks. Well, it's funny how I said that. I don't think you're high. I'm not insinuating anything, DMB, but you might be on the high end of the guesses. Dodie Sweeney, you can send it to my burner phone, or one other way is to reach out to Mrs. R.A. on her YouTube channel, which is Homeschool Ground Zero, and just comment on any of her channels. She is very good about responding to comments on her channel. All right. Lat Cali Girl. Hello from the great state of Texas. Hope all is well. Thank you for being here. I appreciate it. Mr. Anderson is relying on the jury to open the door. Yes, but I don't think they can. I don't think the judge will let them because the jury, I mean, if the judge would allow it, the jury would have opened the doors a long time ago. We would have no doors in this court whatsoever. The jury has asked all the questions. But the jury questions are being filtered through both sides of attorneys and the judge. And there's even times where the attorneys have not objected and the judge sort of said, I think this gets us in a bad territory. And the other side's been, yeah, it probably does. So I don't think the judge is going to intentionally allow a question that will open the door from the jury. He's even gone so far as to recraft the juror questions to narrow the scope to prevent straying into that borderline territory with the Title 39 stuff. But let's see. Where else do we have? This case is making me crazy, says C.J. Martin. I'm reading the transcript of the shelter hearing, really trying to figure out the missing piece to this puzzle. That transcript of the shelter hearing, I think that's one thing the jury will not get. I think they won't get anything about that Title 39 stuff. Plaintiff attorneys are Anderson, Whitney. Defense attorneys are Shapiro, Crowells, and Hunter. Yes, Anderson has been the one that's been really spicy on cross. Oh, look, this is where we are. We're current in the counter as it's scrolling on the screen. And you can see who's coming up here in just a minute. Ricky Watson in just a few. I see you there. Just looking at who's coming up and their guesses. I think we're going to pass all these people today on the objection count. Welsh law student, sorry about that. You might. Shells, there you are. Detect Vids. Oh, judge is back. Okay, so we're gonna go ahead and pause this a little bit and scroll back to where we go, where we should go. There we go. Boston girls up top.
Everyone's back from lunch. What's the next issue?
Your Honor, we need to make a motion based on the question from plaintiff's counsel through the last witness. Question from Mr. Anderson was, isn't it true you testified you don't have any remorse for any of this?
Here comes a mistrial.
The question was timely objected to. According to the law in the state of Florida.
Mr. Hunter asked me to instruct the jury to disregard the last question, which is what I did.
Yes, Your Honor. We appreciate the instruction. The law requires us to make the timely motion for mistrial at the time of the statement, which we would have done after lunch, but I know Your Honor had to go. Just to make the record on this, Your Honor, State Farm Auto versus Thorne at 110 Southern 3rd 66, a Florida 2nd District case, held that it was improper and mandated reversal for new trial, where plaintiff's counsel suggested in closing argument that the defense was never taking responsibility, and shame on these defendants. Again, in Intramed v. Guider at 93 Southern 3rd 503, the 4th District found the plaintiff's argument that the defendants never took responsibility and never apologized was grounds for a new trial. And again, in Cohen versus Philip Morris at 203 Southern 3rd 942, the Florida 4th District also said that counsel's comment during closing argument that the defense never took responsibility and failed to apologize were egregious, unacceptable, and grounds for a new trial. Based on the comment made from plaintiff's counsel in the prevailing case law in Florida, we believe we're entitled to a new trial. We were moving for a mistrial on that basis at this time.
Plaintiffs, what do you want to say?
This is a punitive damages case, and the issue of whether or not the defendants are ratifying the behavior, approve of the behavior, and otherwise have decided that. And actually, what her statement was, I was getting to, was at the end, she says, I did everything fine. I don't believe I did anything wrong that to my question about have you checked back with her and then do you have any remorse over this? And so in a punitive damages case, it's a little different situation. I haven't studied the defense's case to see whether any of them were punitive damages cases, but the court made an instruction at that time, and we certainly don't believe that it rises in any. I'm not sure it's error on my part. From what I've read, I would have to study it, but it certainly doesn't rise to the level of a mistrial.
Well, one, the court already instructed the jury to disregard the question. There wasn't an answer to the question. The court has previously and will in the future again instruct the jury that that Johns Hopkins Children's Hospital is not responsible for the call it the Chapter 39 stuff, just because it's probably the easiest shorthand to say at this time. I don't think that there's any need at this point for a mistrial on a question that was asked that was never answered.
Your Honor, the second issue we would like to address briefly is we prepared a special instruction that we'd like the court to deliver now regarding suicide. May I approach with it?
Sure. Has this gone to Mr. Elegate?
It's gone to Mr. Anderson today. It was based on the jury's questioning today, and it goes to the fact that the court has already dismissed on summary judgment the duty owed to Beata Kowalski to prevent her suicide. There were a number of questions from this jury, and I thought it would be the defense is requesting, based on the timeliness of it, that a short statement be read to the jury to make it clear that we do not have a duty to prevent Beata's suicide based on the questions that they're asking.
Your Honor, this is kind of, if anything, I guess I would characterize it as a self-inflicted wound. We asked no questions on cross-examination of Dr. Teta Sanchez before the jury's questions. The defense brought out from her several statements allegedly made by Beata Kowalski to Dr. Teta Sanchez about being exhausted, being overwhelmed, and then further statements that later on she stated she was okay with the family. And then stepping into territory we've been prohibited from entering. Then there was discussion on direct regarding the propriety of Baker acting someone and those types of issues. So to give an instruction based on their own questioning, we feel would be unnecessary and improper.
I agree that Mr. Hunter asked a question that elicited this issue, and
this is strategy.
I don't think there was an objection because I was thinking there would be, because it's not an issue in the case because it's already been summary judgmented out. I don't think there's a need for a jury instruction at this time. There you go.
That could have been the whole reason for no cross right there.
What's next?
Knowing that she was talking about this.
Well, Mr. Anderson brings up, we learned just before lunch that the defense plans on calling Detective Graham tomorrow. I think Ms. Crawls and I discussed this briefly. We'd like to discuss this after the jury's gone for the day. Our objection to having Detective Graham testify. We do have a motion for a curative instruction as well that was filed yesterday. And it deals with it's within the motion you looked at earlier, so there were two proposed curative instructions in there. And the one that we'd like to discuss now had to do with the argument concerning Dr. Richards' testimony and the suggestion that the Kowalskis, suggestion by defense counsel, that the Kowalskis had moved for a continuance of the dependency proceeding. And for that reason, and then that there was a final hearing scheduled in February.
Does this have anything to do with the witnesses this afternoon?
It does not. It does not.
We can talk about that this evening. Anything else about what's going to happen over the next few hours?
No, Your Honor.
No, Your Honor.
We have 5 minutes. Why don't we use that for exhibits?
So the plaintiff not crossing Dr. Sanchez, the defense elicited the testimony that they're objecting to from the jury questions. So they're saying that basically they were the cause of the jury having that question, and the judge's not going to grant that
30-40
direction
Judge, second page.
because of that. We'll get into that when we've got a bigger pause.
What is this?
This is Pediatric Pulmonary Associates telephone documentation. From June of 2015. I guess just one page.
So we have at least one more objection there, right?
Help me out. That's what it said. Maybe make it larger.
It says new to office, recent admit, new cough constant.
New what?
Cough.
New cough?
Cough constant, albuterol, or something just given.
It gets into the medication action plan for.
It's got to be
Prednisone.
Ms. Crow.
Yeah, it says it gives the medication, the prednisone, when to give it.
Explain an offer to take to EC.
And the emergency action plan for her asthma. And it's in June of 2015.
I don't think this is a legal objection, but it's indecipherable. And
Also, Dr. Gondor is one of Johns Hopkins.
Can we just have one per?
One horse, one rider.
I didn't hear a legal objection.
Okay. Objection, relevance, hearsay. I'm not even sure who wrote this, knows, and we can't read it. And that doesn't seem the defense can either.
Well, it's coming from a doctor's office.
Yes, it's Dr. Gondor.
Okay. Court's going to overrule the relevance, and I don't think legibility is a
It's not a legal
basis
standard.
to keep something out when we're talking about doctor's handwriting.
Nothing would be coming in if
3041
it
is
was.
the...
Or my handwriting, for that matter.
I'm sorry. 3041 is the surgery center for the pinky fracture that's been discussed.
For the pinky fracture, okay.
The one in
This is
2020.
2020, okay. Now, how many pages is this one?
It's 26 pages, but I don't know what the objection is. I don't know how they could say it's not relevant. There's been testimony about her visit, when she went, when she delayed, complaints.
Seems like maybe perhaps the amount should be redacted, but no objection otherwise.
The amount?
The bill? You mean the bill?
Yeah, the $10,200.
We can.
I'm not sure if that's reflected on other pages here.
Can you scroll through the other pages real quick? Keep going. Keep going. These are just normal medical records?
Yeah, that's my understanding, Judge. I haven't personally looked at each page, but that's my understanding.
She may be the visiting
As long as
doctor.
you agree to take out the
They have rotating doctors.
money, that's fine, but otherwise,
Visit.
the court will receive
All right, so-
3041, and I'm assuming it's pages 1 through 26 is the complete.
Right, I believe page 1 was the bill, so it'll be 30412 to 26, then, Judge.
Okay, what Ms. Corliss just said.
Okay. 3042.
This looks like Dr. Kirkpatrick stuff.
It is.
Why don't we,
Want to delay that?
yeah, and
Sure.
we're now at 1:30, so.
Sure.
Let's go ahead and bring in the jury.
Okay, jury's coming in. We're going to get started here just momentarily. Let's see if we can switch some things around here. There we go. Oops, I still need to be here, sorry. I hear you, Mr. Brooks, there in the background. All right, Dr. McDreamy, if you can translate the chicken scratch notes, that would be great.
Okay, please be seated, everybody. Members of the jury, I want to confirm while you're away you did not discuss this case amongst yourselves. You did no investigation and received no information. Is that all correct? And did anyone approach you while you were away? And did you see any media coverage about this case while you were away? Did you have a good lunch? Yes. Okay, good deal.
We're doing some next level audio work on this. We're actually.
Did I hear always?
We're raising the quiet voices without raising
That's
the
a very
loud
strong
voices.
statement.
So it's unfortunately also raises the paper voice.
I just want to know what plan
Hey, Jules.
that is on, because I don't always get that. So.
I'm sorry, who was the defense calling?
The defense calls nurse practitioner Joanna Klink.
Nurse practitioner Klink is coming up. I think Maya did leave earlier this morning. She was here initially, but some of this testimony was probably pretty rough to sit through. And she left at some point. I don't know when. Maybe Jules can tell us if she knows. The way this witness is glancing around the courtroom, I think she's very nervous.
The testimony you're about to give will be the truth, the whole truth, and nothing but the truth.
I do. All right, right this way. Yeah, good and wrong. I have a seat in that witness stand.
Good morning, ma'am.
Good morning.
Good afternoon. Can you please state your name?
Johanna Klink.
And what is your current occupation?
I'm a nurse practitioner.
Can you please give the jury the benefit of your education and training, beginning with college, and any degrees or licenses you obtained over the years, please?
Yes, I have a bachelor of science degree in biology. And then I went on to become a nurse, so I have a bachelor of science degree in nursing. Then I was a nurse for some years, and then I went back several years ago and became a nurse practitioner, and I'm a family nurse practitioner.
And when did you first become a registered nurse?
2001.
And when did you become an advanced practice registered nurse?
2021.
Can you explain the difference between a registered nurse and an advanced practice registered nurse?
Yeah, so a registered nurse is most typically a bachelor's degree. Sometimes it's an associate degree, but for the most part it's a bachelor's degree. The nursing, with a registered nurse does is follows the orders that would be given by a nurse practitioner, which was considered a mid-level, or a physician. So we follow the orders. We monitor vital signs. We monitor the patient, and then we report to the physician. A nurse practitioner is one who works between, is like considered a mid-level, and will write orders and make a diagnosis. And registered nurses don't make diagnosis. They follow the orders of a physician or a nurse practitioner or physician assistant.
Now, before you became an APRN, can you describe your work history as a pediatric intensive care nurse?
As a pediatric intensive care nurse, I started in Children's National Medical Center in Washington, D.C. I was there for 2 years, and I was in the pediatric intensive care. I was for several months in a respiratory care floor in the acute care, and then I went straight to the pediatric ICU. After that, my family and I moved to Seattle, and I worked in the pediatric intensive care in Seattle. While I was in the pediatric intensive care in Seattle, I also had experience in cardiac ICU, some in the neonatal ICU, but predominantly it was in the pediatric ICU in Seattle. Then my family and I moved from Seattle to Florida, and then I worked at Johns Hopkins starting 2010 until I believe it was 20, something like that.
And when we say PICU today, you understand that to be the Pediatric Intensive Care Unit?
Right, we call it PICU, but it's PICU, Pediatric Intensive Care Unit, yep.
Can you give the jury an idea of what a PICU nurse at All Children's Hospital, or anywhere for that matter, does on a daily basis?
Well, the pediatric ICU, like I said, we follow the orders of the doctor, nurse practitioner. We're there for monitoring vital signs, patient status changes. We report to them when we see changes in status. We administer in the pediatric ICU and in the ICUs very specialized drugs that are not given. That's pretty much what we do. We take care of the patient. We give them, we look after their skin. We turn them. We help them. We give them their medications.
Did there come a point in time that you came to be involved with the care of Maya Kowalski?
Yes, I did.
And am I correct that you served as Maya's bedside PICU nurse on October 7 of 2016?
Yes, I did.
And in addition, I believe that you also served as a PICU charge nurse at All Children's Hospital at a few points in Maya's admission as well. Is that correct?
Yes, I was.
Can you please describe for the jury what role a PICU charge nurse serves?
Well, the PICU charge is more of a supervisory role. We control kind of the flow in and out of the ICU via admissions, transfers, discharges. We're there for staffing. We assign patient assignments to the bedside nurse. We also go to rapid responses on the floor, and that's where in another unit outside of an ICU, if a patient is having some type of a respiratory or cardiac decompensation, the charge nurse will go there and assess the patient if they need advanced treatment, if they need any kind of CPR. We're also there for the code blue. If y'all know, the code blue is when somebody's in a cardiac respiratory arrest. We're there for that. And we monitor patient flow. We keep an eye to make sure that the nurses have what they need for their job that day. We go to the staff meetings, and we also go to oversee what's happening with each patient in a big picture.
When you encountered Maya Kowalski at All Children's Hospital on October 7 of 2016, how many years of nursing experience did you have to that point, approximately? I
had about 16 years of pediatric intensive care. No, yeah, it was about 16 years. It was in 2006, yeah.
I'd like to take you back in time to the afternoon of October 7 of 2016 and pick you at All Children's Hospital. On that date, you served as Maya's bedside PICU nurse, correct?
Correct.
Do you remember the afternoon of October 7th?
I do.
Okay. And why is it that you remember that afternoon?
It was an unusual day. It was a very stressful day. I remember distinctly when the admission came in. It was challenging. There were many things that had happened that day that stay in my mind as the day progressed.
We'll talk a little bit more about that, but do you have anything else you remember specifically about that day you want to tell the jury about?
I got the report from the ER nurse and said that this patient was coming to me in the pediatric ICU. She gave me a brief history of Maya's medical history, what was most likely the plan was for her that she was needing to have. They said that she was having pain and that she had a pain diagnosis, and that she was going to come to the ICU.
And am I correct that when you first encountered Maya and her family, you performed an admission assessment in the PICU?
I did.
And can you please tell the jury what an admission assessment is?
An admission assessment is a complete, it's a profile of the potential needs that the patient is going to have when they're in the ICU. The admission assessment will be things about pain history, if there's any spiritual needs that they may have, their regular diet, any safety issues, who lives with them, their whole background. We do and keep that profile of the admission assessment.
And part of that assessment is obtaining a history?
Yes.
And who was it that provided you with Maya Kowalski's medical history during your admission assessment that day?
Mrs. Kowalski was at my side right here. I was at the computer right here, and Mrs. Kowalski was reading the computer with me, and she was giving me all the information, answering the information with me.
Did you observe any language barriers when communicating with Beata Kowalski?
No, there was none. Mrs. Kowalski was a nurse herself. She knew medical terminology. There was no. She was proficient in English. There wasn't any communication.
Now, moving a little past the admission assessment, do you have any recollection about difficulties with obtaining vital signs for Maya Kowalski on October 7th?
Yes. When a patient comes into the ICU, we get a full set of vital signs. We get their height, we get their weight. If it wasn't done in the ER, sometimes we'll do it again. But Mrs. Kowalski would not let me take a blood pressure on Maya. She said it was going to cause her pain. And I said, well, we need to have a blood pressure done on her. And she said, well, if she has blood pressure taken, that she needs to be pre-medicated for the blood pressure. I'd never heard that in all those years. I'd never heard of it. And I knew that they said that she had pain, but I'd never heard, and I've had patients with pain issues, kids with cancer and things, but she needed to be pre-medicated. And so we held off on it for a little bit. I was able to put her on the monitor. I was able to see her heart rate and her respiratory rate, her oxygen saturations, it's how much oxygen her blood had. Those were really, that was critical to have that part. And we deferred the blood pressure for a little bit until I can talk to the doctors and see what do we do to give her pain medication for the blood pressure. So we held off on that for a little bit, and we're going to revisit that.
Now, am I correct that you had the opportunity to observe Maya Kowalski at various points on October 7th?
Yes.
Do you have a recollection about Maya's mobility within her bed while she was in the PICU?
Mrs. Kowalski told me that Maya can't walk because of her CRPS, and I took her at her word for that. I mean, that was okay. I understood she had some issues, medical issues in the past and now. Except then I saw Maya was on her knees on the bed, and she was moving around on the bed on her knees. And I was like, Maya, you're moving on the bed. And in the hospital, it's hard to move on your knees on a bed, on any bed. It takes a lot of strength to do that on a bed. But this was an ICU bed that had an air mattress. So with these air mattresses, you sink into the bed. And to be able to move like that while you're sinking, I thought was a little bit suspect. Like, how did you do that when you can't walk? You had your legs were so profoundly weak, but she was able to do that. It's like walking on a moon bounce on your knees. It's hard. So I did mention to Maya, like, Maya, look at it, you're doing good. You're doing good. Maybe you could do something. You could walk. Maybe you can try. So I did notice that was unusual.
And at various times from your vantage point while observing Maya Kowalski, were there times that she appeared agitated?
Yes.
Okay. Were there times that she appeared upset?
I'm sorry?
Were there times that she seemed upset?
Yes.
Did she appear withdrawn at times?
Yes.
Were there times, though, that you observed her that she didn't appear upset, agitated, or withdrawn?
This happened most often. It happened very often. And this was strange, too, is because Maya's behavior did change when she was alone with me, or even as I was charged and the nurses would give me a report, they would say the same thing. And I saw this, that when Maya was with her mother, she was a different girl. When she was alone, she could be very sweet, age-appropriate, 10-year-old. And she would be a nice little kid. And when Maya's mother came in, the whole demeanor changed. Things changed. And she shut down. She became withdrawn. And that happened consistently.
When you say consistently, can you approximate how many times over the afternoon of October 7th you observed this change in demeanor based on who was present?
So on October 7th, when that happened a couple times. There was one time when I was having a conversation with Maya, and she was talking to me, and then her mother came back in the room, and everything just stopped. She shut down, and it happened then. I don't remember how many times that day that happened, but I remember distinctly that happened, and it happened again on other days in the ICU.
And did you have the opportunity to observe Beata Kowalski's demeanor and behavior in the PICU on that day, October 7th?
Yes.
And how did Beata Kowalski behave in the PICU?
Mrs. Kowalski, when she came in from the beginning, I don't know why, Mrs. Kowalski was very agitated as soon as she came in. I felt like I was starting to walk on eggshells, like she was demanding. She wanted this. Even when I was doing that medical assessment, or the hospital intake and assessment, she was right there answering the questions. And I was thinking, okay, maybe that's all right. People don't usually do that, but okay. But she did control the whole thing as I'm going through checking, and it was, I could have said, hey, why don't you just answer all of this? So she was very demanding, and I just felt like she became agitated, and if I didn't do what she wanted, then she would be agitated.
At any point do you recall any swearing or yelling in the PICU that day on October 7th?
There were a lot of F-bombs that had happened in that day. I don't remember all the specifics, but I remember the swearing started. Yeah, I do. I remember actually with both of them, with Maya and her mother, that there were a few F-bombs.
Do you recall at any point Maya using profanity directed at any of the staff members at Johns Hopkins Children's Hospital?
I do.
Why don't you tell the jury about what you recall?
So I was charge nurse on that day when it was directed at the staff that I witnessed. So in the hospital, in the ICU, we have like a morning rounds, and you have the team together, and there's the residents, and dietary is there, pharmacy's there, nursing's there. Everybody is there, and we go to the patient into the room and then talk about what happened that night, and then what the plan is for the day. And I was the charge, so I go along with the rounds to each patient. And we walked into Maya's room, and Dr. Tepa was the attending that day. So we had just walked in, and I think she says something like, "Hi, good morning," and she's like, "Well, we're something along the lines of like, we're having a new day, or we're gonna, talk about your plan of care," which is what she normally says. And then, Your Honor, is it all right if I say it?
First, objection, hearsay. Second, narrative.
Sustained.
And not responsive to the question. Move to strike the last 10 lines.
Just ask your next question.
Why don't you tell the jury about the incident where Maya Kowalski used profanity in your presence?
Well, in my presence, so she was saying the F-bomb, "I want my effing I want my effing sedation. I want my effing sedation. Then she called Dr. Teppa. I was there, she called Dr. Teppa an F&AH. She said, "Shut up, you F&AH."
Was that something that you found unusual in your experience as a PICU nurse?
Yes.
And why was that?
Well, here's this 10-year-old little girl, and it was unprovoked. Like, it was a morning, we just walked in. I don't know why that happened. I don't know where that came from, but she said the whole word, and we were shocked. I was shocked. I saw Dr. Teppa's face. It was like, I don't think anybody had ever said that to her. She gasped, and we all looked at each other and were in shock.
Objection, non-responsive to the question.
Overruled.
Ms. Klink, I'd like to now go through a few of the entries that you made in Maya Kowalski's medical chart the afternoon and evening of October 7th. Okay, Clay, can you please put up Joint Exhibit 1001 2722? It is in evidence. And I'd like to draw your attention specifically to the note here from 1700. It's under the text note T900. It says, "I want my sedation. I want to eat. I feel like I'm having a heart attack." Mom replied, "Well, honey, if you have a heart attack, at least the doctors will treat you." Do you see that, Nurse Klink?
Yes, I do.
And is that a note that you entered on October 7th?
Yes.
Why is it that you put that entry into Maya Kowalski's medical chart?
Well, there were a couple reasons why I put that in. First of all, she said that, and that's why I put it in quotes that way. Secondly, I thought it was unusual that she said, I want my sedation. She didn't say, I'm in pain, nurse, my arm hurts, mom, my leg hurts, my back hurts, I'm in pain, I have an owie, somebody help me because it hurts. She said, I want my sedation. And I thought that was unusual for a 10-year-old. Kids don't ask to be sedated. They ask for something because they have something hurts, they have an owie, they have something bothers them. They'll say that, but they don't ask for sedation. So that I thought was very strange. So I put that in. And then the other thing is,
and I was going to get to the next one, Nurse Klink. There's a second note here, T901 from 5 p.m. on the 7th. It says, well, can you see it? We've got it highlighted here for you, I believe.
Yeah.
Quote, "I'm tired of all these lies. My life is a lie," end quote. Clay, yes. Can you highlight that, please?
Objection. Reading from the record. Strikes.
Let's try not to read the records.
Nurse Klink, do you see the entry here that's highlighted before you? Can you tell me, or describe for the jury rather, what was going on around the time that this statement that you quoted from Maya occurred?
I was alone with Maya in the room in her hospital room when this happened. She was saying that she was hungry and she wanted a donut, but she said about the sedation part, and then she said, I'm tired of all these lies, my life is a lie. That struck me very hard. I don't know how to explain it. When she said that, it sounded to me like it was a cry for help. Like there was she was desperate. She said those words to me, and I said, Maya, what do you mean by that? And Maya's, before that happened, Maya said to me, where's my mother? And I said, well, I think your mom is with the doctors. They're having a meeting. And then she was saying, I want my donut, I want my sedation, and then she said that. So Mrs. Kowalski and I believe Mr. Kowalski were in a meeting with the doctors. This was right after she was admitted. I think this was like soon after she was admitted. I didn't have any background. I didn't really know that much about Maya. I certainly didn't know anything along, like now that I look back on this. But that struck me as very, very unusual. It was like a cry for help. I don't know, so I put it in there. And as soon as it looked like she was about to answer me, and I remember distinctly, she paused when I asked her, Ryan, what do you mean by that? She paused, and then she looked like she was about to answer, and then Mrs. Kowalski came in the room, back from the meeting with the doctors, and then that was the end of it. And this was the first day, this was right after she was admitted to the ICU. And I thought it was unusual for a 10-year-old to say, I'm tired of all these lies, my life is a lie.
What do you mean that this was the end of it? I think you just told the jury that when Ms. Kowalski came back in.
Well, that was the end. Maya became withdrawn again and kind of shut down, and I went back and did the rest of my work, checking on meds or whatever, but that was the end of it. That was the end of the conversation. She said that. I asked her to explain more. It looked like she was about to, and then her mom came back.
In your almost 20 years of nursing experience now, have you ever had a child tell you that their life was a lie?
Never.
Were you concerned by that statement?
Yes, I was very concerned. I mean, I don't know anybody, any kid, any child that would say such a thing. And she said that, exactly that. And that did strike me as, why would you say that? What does that mean? That meant something, and I could see she said it.
Going back to your entry here about Maya requesting sedation, do you recall the tone of her voice when she was asking for sedation?
Maya was agitated. She was angry. She was yelling. She would say, I want my effing sedation. She was upset. She was agitated.
In your years of nursing experience, have you ever had a 10-year-old ask you for sedation?
I've never had any child ask me for sedation, to say, I want to be sedated.
Now moving forward, after you were the bedside PICU nurse on October 7th, am I correct, you were the charge nurse on the PICU for a series of days after October 7th?
Yes.
And you were charge nurse for a few days while Maya Kowalski was in the PICU, is that correct?
Correct.
Can you please describe for the jury some of the recollections you have serving as a charge nurse during those days while Maya was in the PICU?
Objection calls for narrative answer specifically.
Sustained.
Okay. During the period of time that you were a charge nurse on the PICU, did you have any interactions with Maya Kowalski or her parents?
Yes.
Okay. Can you please tell the jury what you recall about those?
Objection again. Narrative.
Overall take time.
You can answer.
Can you repeat that last part?
Yeah. So during the period of time that you were a charge nurse in October in the PICU, can you please describe some of your interactions with Maya and her parents?
I was in one of the care conferences.
And let me stop you there. I'll represent you. There was a care conference on October 11 of 2016. Does that sound about right to you?
Yes.
Okay. And why don't you explain for the jury what a family care conference is?
A family care conference is when you get the different teams together, and sometimes there's discharge planning. You get the different teams. Sometimes if it's a child with lung issues, then the pulmonologist would be there. The charge nurse is there. The physicians are there. The parents are there, and that's a care conferences is where you get everybody together all on the same page at the same time and figure out a plan of care.
And what do you recall about that meeting?
I remember it was in the morning. I was charge nurse that day. I was there as an observational. It was the physicians were there with Mr. and Mrs. Kowalski, and I remember that the ICU team were talking with the parents about the plan of care, what they're going to do with Maya's care. And I know that they were working towards trying to get Maya into some type of a stable medication or stable regimen where she wasn't on a lot of these ICU meds. Some of these meds are dangerous meds, and to try to wean her off those meds and get her into some other type of like a therapy, cognitive therapy, maybe just some physical therapy, occupational therapy, and try to get her stabilized on that and take her down from a lot of these ICU meds that were like ramping up.
And what do you recall about Mr. Kowalski and his position about what the doctors were requesting and recommending during that care conference?
Mr. Kowalski and Mrs. Kowalski were sitting kind of on this corner. I was right here. And he said to her, he's like, I think this makes a lot of sense. I think we should do it. I think it's reasonable. Why don't we give it a try? It's what they're saying. It's okay. We should just try it and just see it. They seem like it seems like it's a reasonable plan.
Narrative answer. Objection. Motion to strike.
Sustained.
Okay. During this conversation, the care plan conference, what do you recall Ms. Kowalski saying in response to Mr. Kowalski's request to stay at the hospital?
Say that again?
At this care conference we've been discussing, what do you recall about what Beata Kowalski was saying in response to Mr. Kowalski's suggestion that we listen to what the doctors at All Children's wanted to do?
Mrs. Kowalski did not want to entertain any other plan other than continuing with the ketamine and the propofol and the ICU drugs.
Did it appear to you as though Mr. Kowalski wanted to have Maya Kowalski stay at Johns Hopkins?
Yes.
And at the end of the care conference, do you recall if the Kowalskis agreed to stay or not?
I believe they did. That would you'd have to check on with the physicians to find out the final, but I believe that, yeah, they stayed. They chose to stay.
Do you recall during this family care conference on October 11 of 2016 any threats to the Kowalskis that they would be arrested if they didn't stay at All Children's Hospital?
No.
Have you ever, in 20 years of nursing, heard any hospital staff member threaten a parent with arrest if they wanted to leave against medical advice?
Objection, foundation, predicate, and
sustained hearsay. And welcome, come forward.
Mr. Anderson's getting his objections in here. I can't wait for cross. I want to see what's going to happen here. Clearly, this witness is testifying contrary to a lot of the claims that the plaintiff has made. So I think they need to address this in cross to try to either discredit this witness, which would probably be the easiest method. If they can discredit her, then anything that she says would is possibly will be disbelieved by the jury. Who's doing the questioning? Is it? Oh, it's Mr. Hughes, huh? Mr. Hughes did question one other witness in this trial so far, and after doing the direct, he felt sort of ill and left before cross, and it was brutal. It was brutal. But I think the judge is instructing Mr. Hughes just a little bit to craft his questions to the witness a little bit more narrowly, to sort of stop the narrative, I think, is one of the most sustained objections that we're hearing from Mr. Anderson. Yeah, this case is not an easy case. This has a ton of, not just from a legal perspective, but there's just a ton of information, a ton of data, a ton of players, a ton of data. That I said data twice, but there's a lot of data in this case, and so much to consider. The jurors really have their hands full, and they're only halfway through. So. Last witness characterized Beata totally differently from this witness. I definitely feel from this witness that she was not a fan of Beata. That she was, she's the charge nurse. She's in charge. She knows what's happening, and here's Beata telling her what to do, and that's not how it works. That's the vibe, the underlying vibe I've gotten from her.
Was there ever a time that you saw Mrs. Beata Kowalski request the anesthetic propofol?
Yes.
Okay, what is propofol?
Propofol is it's a sedation agent. It's used usually for procedures. It gives it's a deep sedation, and it's used in ICUs. It's used in ORs. We'll use it. Not really. Sometimes in an ICU for procedures, for doing a procedure at the bedside, a significant procedure.
And what do you recall about this incident where Mrs. Kowalski was requesting propofol?
I don't remember all the specifics. I know that she wanted propofol. I don't know why. It's usually a sedating agent, and I remember thinking it's for sedation, and I don't know why Maya would be sedated, but she kept insisting she wanted propofol, and I thought that was unusual to have for propofol in that situation.
Were there ever times that you recalled Mrs. Beata Kowalski requesting sedative drugs around the time that Maya was about to go to sleep?
Yes.
And did that strike you as unusual?
Yes, and there was a couple.
Foundation, predicate, knowledge, all of that. Overruled.
You may answer.
So there was a couple times when Mrs. Kowalski wanted me to give Maya some pain medicine. And one time she said to me, she's like, one time Maya was almost asleep. Her eyes were drifting off. She was resting comfortably, and Mrs. Kowalski went to Maya to wake her up and said, "Maya, are you in pain?" And I thought, oh, you don't wake her up. She's sleeping. And that was one time that she did it. Another time, she was saying, she's in pain. She's in pain. You need to give her pain medicine. And normally, I will work with the parents 100%. I had been in ICU for a long time, pediatric ICU for a long time, and I work with the parents if they think that. But this time, this was different. She was saying, she's in pain. She's in pain, and I really didn't want to get involved. I didn't want to answer because I just thought she was not in pain. And then Mrs. Kowalski said to me, "Don't you see she's in pain?" And then I thought, okay, she actually asked me then, and then I looked at Maya. Maya was completely calm. She was quiet. She was laying in bed comfortably. And then I looked up at the monitor, and I see she has the low resting heart rate. She had a low respiratory rate. And I said, no, I don't see she's in pain. And that was unusual for me because, like I said, I don't want to be stingy. I treat pain very seriously. I especially treat children's pain very seriously. But it was obvious that Maya was comfortable, and I could tell not only was she resting, but you can see on the monitor her heart rate and her respiratory rate were low. And if I give her pain medicine, that can bring her respiratory rate down too low. And that struck me as very, very odd. I was nervous to even go ahead and do that, because if somebody's really in pain and their heart rate comes down from 150 to 120, that's okay. But if the heart rate is 70, 80, and now I'm bringing that heart rate down because of the pain medicine or the respiratory rate, now we're in trouble. So, yeah, that kind of stuff was happening, and then, yeah, that was distinctive to me. That stuck out.
Nurse Klink, from your vantage point as a PICU nurse, were you concerned for Maya's care and well-being when she came into the hospital on October 7th?
Of course.
Thank you. Your witness.
Here goes Mr. Anderson.
Wow, with all that experience, you must have been really good at charting everything that was important, right?
I chart what I can get in there, yes.
And what's important, right? Mm-hmm. Really, if something astonishing happens, you're going to put it in there, right?
Nurses chart as much as they can get, as much as they can chart, as long as they're doing their patient care as well.
Well, why is it that, and I can approach and show the witness, from in all of your charting here over a few days, most of what you said about all the words and all the actions is never charted. Why is that?
Well, first of all, we do chart all the vital signs. We chart the meds. We chart what goes in the patient. We chart what comes out of the patient. Those are things that we for sure we chart. We get in there from the medical point of view. The other stuff, if we can get some time to put the things that some of them are glaring. The incident with Dr. Teppa, where she called her that name and she said the whole words, the whole thing. I only gave the initials, but she said everything. The reason I didn't chart that is because most of our charting that we do for that is a communication tool in the hospital. Like, I wanted, if we chart that the patient got out of bed, because when physical therapy comes, they will look at the child's chart and says, oh, okay, the kid was out of bed today. So something like that is what I would convey to the ICU team, specifically to the attending that's there. And Dr. Teppa was in the room. So this was during rounds. Everybody was there. Anybody that needed to know about what that kind of those expletives, anyone was already there. There would be no reason for me to chart it. If I had thought that I was going to be here where I am now, yeah, maybe I would have charted it. But Dr. Teppa knew. We all knew. I'm not going to. It's more that kind of stuff is for the purposes of communication in the hospital. I didn't think I'd be here.
Anything else?
That's it.
On your explanation. Sure.
He's letting her run, giving her a chance to.
I chart what I can chart. I mean, there's 12 and a half hours that we are there in the bedside. We are running. We're monitoring the patient. These kids are critically ill. We don't chart everything that's a communication that comes out like that. And like I said, the thing with Dr. Teppa, yeah, maybe I should have, in retrospect, if I knew I was going to be here, but at the time, anyone who needed to know was there.
Aren't you allowed to have either your phone or a cell phone from the floor on you as you make your rounds?
I believe we are, or we were.
Why is it, after 12 hours of all of this, there isn't a single photo or video or surveillance or anything else that confirms what you're saying?
Well, there's no cameras in the room. This happened in the patient's room, right? They don't have, unless they need to put it up for a specific reason. But there's cameras in the halls, and we're not allowed. I don't take pictures of any patients. We're not allowed to take pictures of the patients. I don't videotape the patients. I don't do that.
I see. So you nurses are not allowed to take pictures of the patients, right? Isn't that what you just testified to?
Yeah.
Okay. So I guess taking her into a room and stripping her down to her bra and her shorts and taking about 8 to 10 pictures of her, that would not be appropriate, would it?
Objection form. Overall form. Foundation. You can answer.
There are times when there are pictures taken, absolutely. They are taken for purposes, for medical purposes, 100%. And that's undeniable. But for me to just do it on my phone, to take a picture of the patient, I don't have any reason to do that. If it was a medical reason that somebody needed to do that, that does happen. That I know happens. People do that. I know different entities will do that. But as the nurses, no, I'm not going to take, I don't take a picture of a patient on my phone. Maybe unless somebody else has a reason to do that, possibly, but I don't. I'm answering for myself. What other people do is you'd have to ask them.
Anybody, anything else
No.
you'd like to add? Okay. So if somebody were, say, to take a child and put them in a room and videotape them without their parents' consent or their consent, that would also be something that would be against your policies. Agreed?
I disagree.
So it's okay to videotape children without the parents' consent or anyone's consent but you, correct?
That's not what I said.
Well, if it's not the parents' consent and it's not consent from another authoritative source, that leaves you, right? So
Sustained.
So, do you or do you not have the authority to do what I just described? Take a child into a room under false pretenses of an EEG and put her in that room, video her without her knowledge. Oh, put a commode just out of reach to see if you can tempt her to get over there. So, who gives the authority to do something like that?
Objection, argumentative, compound, foundation.
Sustained.
Are you? Do you work with Kathy Beatty at all? Ever?
I did in the past.
Not anymore.
Correct.
Not since she left, right?
Correct.
And before that, though, was she a PICU social worker?
Yes.
Were you a PICU nurse?
Yes.
So you saw her about every day, right?
No.
How often?
Maybe once a week, once every 2 weeks. And if she had a patient that involved me, we had the same patient at the same time, then I would. But if I had a patient that Kathy Beatty wasn't working with, then...
Okay. So with as stunning as all of this is, I mean, with a 10-year-old Mike Kowalski throwing around words like this, you would have mentioned that to Kathy Beatty, right?
Objection, argumentative.
Rule.
You can answer.
No, not necessarily.
Well, wasn't she assigned to Maya and to move between floors with Maya?
I'm not sure what happened on the floor. I don't know if she was assigned on the floor. I don't have no knowledge of what happens on the floor. I don't know. I didn't recall. I don't recall telling her that. I don't recall. You mean when Maya was swearing?
Yeah, any of that stuff.
I don't recall telling Kathy. I don't know why I would tell Kathy. I would tell Kathy if there was a need for maybe some social services, but to go around and no, I didn't see her. I don't remember seeing her to do it. Maybe if something came up in conversation, but I don't recall telling Kathy Beatty. And like I said, the people that were there knew, and that was kind of it. I didn't start telling everybody what happened.
How many nurses and social workers worked in that PICU at that time? We're talking about the fall of 2016.
Oh, I don't know. Probably 40 nurses.
And there are nursing stations at different points, or just one nursing station?
There's different points. We're spread out.
Okay. On the floor, right?
Mm-hmm.
And so you're telling the jury, after all of this astonishing behavior, it did not spread to every single nurse and social worker on that floor?
Not only do I say I'm not surprised that it did not. It should not have spread to everybody on the floor.
Okay. So you don't think anybody else on the floor heard about it?
I didn't say that. You said everyone on the floor. No, I don't. The ICU is like a dumbbell. There's an area here, and then there's an area here, and then there's like a long hallway. This side doesn't really communicate. This is the east side, this is the west side, and then there's a few rooms down in the middle. No, we don't communicate. So the half of the unit is not going to hear what's going on in this unit, on this side. And no, there's a lot going on. People have a lot of their patients. They have these sick patients. Some kids are very sick. It's hard to explain unless you're there. I mean, some kids are on ventilators, some kids are dying, some kids are close to that, and yeah, maybe people over here would have heard it, but it doesn't mean that everybody there. No, and as a matter of fact, it's something that should not happen, that everybody goes and starts telling everybody what's going on in another patient's room. That's really frowned on, and we try not to do that.
Is this a trap?
Who did know? Say after your care conference.
I don't know. I think the people who knew in the room knew. There was a few of us. There was like the residents were there. I was there. I know there was the dietitian, because after she said that, we looked at each other in shock. The whole room just went still. And then we moved on. It's an ICU. We moved on. And no, I don't think people told other people, a whole bunch of people, but everybody knew in that group, and Dr. Tepper heard it.
But no one out of that charted this afterwards. Okay, Dr. Tepper said something, but out of all those residents and everyone else in that room, no one else charted this in over 1,500 pages of medical records. Do you know why?
Yes.
Tell me why.
Because everybody, it's a need-to-know basis. ICUs with hospital, it's from our point of view, it's a need-to-know basis. If they didn't need to know, it didn't need to go in there. The doctor knew, I knew, the charge nurse when I was charged that day. It didn't need to be told throughout the hospital and in the record. It's not something we would put in there. The things that we put in there, like I said, is more for communication back and forth, if the child ate this or whatever. And especially like in the beginning as well. Nobody knew that we would be here. And she most certainly said that. I mean, 100% she said that. But I wouldn't necessarily chart it. Not necessarily. There's no need for me to put that in there. Hindsight's 20/20, and we look back and say, okay, now we're here. But at the time, nope, it was not something that would go in a chart.
Well, did you all tell risk management this, or was risk management already involved?
I don't know that. You would have to ask risk management. I don't know when risk management was called. I didn't call risk management.
Were you there when Estepa Sanchez called risk management?
I was not.
Did you talk to risk management at any point?
I don't believe so. I don't recall. I don't recall talking to risk management.
All right. So Ms. Winton came down, you never talked to her?
When who?
Wasn't it? Yeah. Ms. Winton.
I don't recall that.
Okay. Somehow the risk management found out. Did it come to your attention? Let's see. All right. Well, you charted on numerous occasions that Maya was a 10 out of 10 on pain, did you not?
I would have to see the charting and see what that was.
Do you remember any of the scores you gave for that?
Not offhand. I'd have to see it.
Okay. Well, I'm trying to find the actual number, but you did show. Okay. You did charge grimace, frown, withdrawn. That ring a bell. You did chart frequent chin quiver, clenched jaw, grimaces.
Your Honor, we'll object. We would appreciate it if the witness could see what Ms. Anderson's reading from.
If she wants it, I certainly will show it to her.
I do remember when I was doing the nursing admission assessment, and Mrs. Kowalski was at my side. And when we got to this part with the pain, Mrs. Kowalski is the one who told me, yes, that, and I remember that distinctly. So I don't know. So she told me when I first came in, like, we asked all the parents, but this time Mrs. Kowalski was next to me. Usually the parents are like on the couch or something. But and I'll ask the parent, how does the child convey pain? Some kids will, bite on their blankie or whatever. So we ask the parents so that we know what to look for, and that's where that originated. So Mrs. Kowalski told me when she first came in, we were checking which boxes to check.
Do what?
Which one?
1001.
Counsel's conversing with each other. We're not supposed to be able to hear that, so they turn the volume down just for a second. Rob says, pro tip, don't say I remember that distinctly. It's an attempt to reinforce your statement that instead makes it sound less true.
Now, you've got, I believe, you've testified to about all of those. Is it your testimony now that Beata Kowalski told you to put all those down?
And Mrs. Kowalski told me when she first came in, when I asked how does Maya exhibit pain, and she went through each one and said, yes, this one, this one, this one, this one. And so then I continued on that's how she exhibits pain. Yeah, I didn't see her frequent chin quiver. But I know Mrs. Kowalski's like, yes, this was affirm this. And so I did.
Okay.
I mean, I didn't say clenched jaw. She told me that that's how Maya has those pain.
All right. So now you charted out, and if we can pull it up, 1001-1056, the nasogastric tube. Got it up? What's a nasogastric tube?
It's a feeding tube that goes into the nasogastrial, so nasal is the nose, goes into the nose, and then it drops down into the stomach, and then you're fed formula through that.
Okay. So then, what may have happened then is that when Mrs. Kowalski walked in, she was a nurse, right?
Correct.
You're a nurse, right?
Right.
Mrs. Kowalski was very dominant about what was best for her child, right?
Objection calls for speculation. Overruled.
Repeat that?
Mrs. Kowalski was very dominant about what she wanted for her child, right?
What she wanted for her child, yes.
Right. And she told you what she wanted for her child, right?
Mm-hmm.
She told you, a nurse, what she wanted for her child, right?
Yes.
But you didn't always agree, did you?
When Maya first came in...
I'm just asking you whether you agreed or didn't agree, ma'am.
Did I agree? What did I... Ask me the question again.
All right. At times, you disagreed with what Ms. Kowalski wanted to do, did you not?
Yes.
Okay. But she still insisted, right?
Yes.
And this was on the PICU floor?
Yes.
Mm-hmm. During the care conference, was Ms. Bagby there?
Who?
Nina Bagby?
I don't know who that is.
Do you recall the security people outside the door during your care conference?
I don't recall security inside the door.
You don't recall two security guys standing on either side of the door during that care conference?
Well, I was inside, so if they came after I was inside, I don't know. I don't recall seeing that. No one told me the security was out there.
Actually, what happened was that Maya Kowalski was in extreme pain when she came in, wasn't she?
This is not a hard
Mrs.
question.
Kowalski said that Maya was in extreme pain.
It was
yes, but you're asking me if I thought Maya was in extreme pain. There were times when Maya's heart rate was so low, she was resting, she's half asleep, and the mother was yelling, actually in my face one time, saying, "She's in pain, she's in pain."
Right.
And no, I did not think she was in pain. She was quiet, she was half asleep, and her vital signs were showing on the monitor. So Mrs. Kowalski may have believed, I don't know what she believed, but she said her Maya is in pain. And then she asked me, and she says, "Don't you see she's in pain?" And I said to Mrs. Kowalski, "No, I don't."
1001-2.
Can you just answer the question that's asked?
Yes.
Thank you.
1001-2326, please.
The judge directs the witness without prompting from either side.
Who's Elizabeth Sumner?
She was an ICU nurse.
Mm-hmm. Experienced nurse or not?
She was a charge nurse at one time, so yeah, I don't know her.
Yeah, you see her ranking it at 10 on the pain scale?
Yes.
And then you go down a little bit more, and there's another 10 on the next entry. One says, like, apparently she was asleep. But on the under over awake and alert, it says 10. See that? And then we go down to Elizabeth Sumner, a 10. Do you see that?
Yes.
Do you see under Kelly Thatcher, a 10? You see that?
Yes.
You see then under Kelly Thatcher, an 8.
Yes.
And I apologize. I said you were in the 10s too, but yours was a 7 and then a 6, right?
Yes.
And then a 7 and a 6, right?
Mm-hmm.
Okay. So apparently she got in more pain during the time because Sumner and Thatcher were on the 8th the next day, right?
Yes.
Okay. So would you agree with me that many people felt Maya came in with a 10 on a 1 to 10 scale in pain? 1001-2450. Maya was also, when she came in, inconsolable, was she not?
She's fighting these answers. And she should just be able to answer honestly and let
I wouldn't say she was. Maya was yelling.
Mm-hmm.
Yes.
Doesn't it say inconsolable?
Well, those are the options they give us.
I see. And then I believe you gave Maya, or excuse me, not you necessarily, but the care team there gave Maya a number of different medications, right?
Yeah.
And those medications included not only the ketamine, but you also gave her tramadol, is that right? And then, where's the meds page? I'm sorry.
This moment of ASMR brought to you by Mr. Anderson.
If I can find it, I'll show it. He'll find it. All right.
They've got the ambient room mic turned up instead
let's
of the
pull up
individual mics.
2045-024. Well, hold on from that. What actually happened was Maya received some medications, right? Then you tried to snake a nasogastric tube down her nose, right?
I don't recall that.
Yeah. And once you tried to snake a tube down her nose, she rebelled, right?
Objection to the extent counsel is testifying and not showing the witness the records.
I don't recall that.
You don't recall having to put somebody else having to help you hold her down while you snaked a tube down her nose? None of that comes back?
No, we do those a lot.
Uh-huh.
I don't recall that. I don't.
And in fact, once people started to grab her and put something down her nose, she really went wild, didn't she?
I don't recall a feeding tube and putting a feeding tube in that.
She went wild because you were hurting her, correct?
I don't recall putting a feeding tube in Maya.
Okay, well. (1001-1056).
This goes for credibility in the eyes of the jury.
No, that's not it. It's 1001-2722. I apologize.
I'll object that note has nothing to do with this witness.
Can you find that too? It's on the narrative on the top. Now putting the tube down her nose. Did somebody else do that?
I don't know.
What actually happened here was that Beata Kowalski challenged you, right?
Objection, argument.
Oh, sorry. We're back. Okay. Please take a look on your screen. Does that say nasogastric tube?
Yes.
Objection again. This document has nothing to do with this witness.
And her name on the bottom. Can we just go with legal objections?
No speaking objections.
And what's the time?
That's her name right there.
Her name is on this, signed by
You
her.
can continue, Mr. Anderson.
Well, it says I reviewed it.
Okay, so you stepped out while they were putting the tube down her nose?
I don't recall doing that. I don't know where the documentation is, who put it in. I mean, if I put it in, possibly, but I'd have to see the documentation because this just says I electronically signed it.
Well, how'd your name get on there?
Because the order came through, but it might not have been done. If the order came through at somebody put the order in at 13:04, At 1319, I saw the order and signed it, but that doesn't mean that the tube went in at that time. That means, okay, yeah, I see that there's an order. I don't know when the tube went in. I don't remember doing it. I put hundreds of tubes in, but I don't know that if I did that or not. I know I signed it, but that's it.
Anything else?
Anything else?
All right. So once you or someone, while you stepped out momentarily, put the tube down her nose or tried to, and held her down to do it, Maya went wild. So when you came back in, you saw her flailing and screaming, right?
Objection.
Is that true or false?
Foundation.
I don't recall that.
Okay. And then after that, there were some cursing in the room, but it wasn't Maya, was it? It was other people in the room trying to hold her down, wasn't it?
I don't recall any of that.
And after that, were you the one that started kind of the narrative that Beata was nuts?
No.
Weren't you and Kathy Beatty telling everyone on that floor, watch out for this mom, watch out for the kid, they're a little crazy?
No.
Sorry, Tom. Your witness.
Your witness.
Nurse Plank, do you remember some questions about pain scores that were entered in the chart?
Yes.
If somebody puts a 10 down on a pain chart, is that something that the patient reports to the nurse?
No.
Okay. So.
Well, if you ask, it depends. If you ask the patient, and you could ask the patient on a scale of 1 to 10, and then they can tell you that it's a 10. It depends if it's a small child, then you use different methods. Maya would know a scale of 1 to 10, so it's possible, most likely, that at her age she was asked on a scale of 1 to 10.
And I think you made it clear, but you don't have any recollection of placing a nasogastric tube down Maya Kowalski's nose.
No, I don't.
Thank you.
Anything further?
No, Your Honor.
Jury?
Incoming jury questions. I really think that Mr. Anderson, at times where he wanted to dig further into certain issues, but he knew that he couldn't, paused intentionally for the jury to write their own questions at that time. Let's see if the questions come in and match up with those pauses. But I think that was strategic on his part to try to lead them to their next question.
I see you're already packing up, so do not discuss this case amongst yourselves. Do not do any investigation. Receive no information.
The jury leaves when there are a lot of questions. They know that it's easier for the judge to discuss this with the lawyers. Well, the jury is out. The witness will also be dismissed into the hallway briefly, which means we get to hear the questions, both the ones that will be answered and the ones that are not, which we like a lot because they're very insightful, even if they can't be asked to the witness for one reason or another.
Nurse Klink, if you could wait outside while we review these questions, we'll call you back in.
Out goes the witness.
The jury is out of our presence.
The jury knows they're so well trained. They hand over the notes and they just grab their bags like, we'll be out in the hall. Call us when you're ready.
Miss Klink's out of our... Just remember, this is not a deposition.
I know, but there's a lot of stuff.
Judge like, just remember, this is not a deposition. Mr. Anderson's like, I know. Apparently, he's got a little more freedom to wander on a deposition than here. Of course, that stuff gets ruled out. And they've killed the mics. No. I'm gonna have to hold tight. I'm gonna tell you what's the judge is saying. The judge is saying, did you report that? Did you follow up at a later time? If not, why? Prior to working with Maya, how many children have you cared for with children with CRPS? When you say these are your only options, inconsolable, do you have the option to free text? I'm just saying verbatim what the judge is reading. No objection from either side on that one. Red number 3. Did you remember the condition of Maya's feet on admission? How many residents were in the PICU on the 9th? During your 12-hour shift, how much is rotation? How much is spent documenting? How or have you ever had any kids in extreme pain use curse words? There's more, says the judge. No objection from Mr. Shapiro. Judge says, this says, not a question. Let me just read it. I'm trying to figure it out. Can plaintiffs, counsel, and defendants refrain from speaking, huffing, and laughing during responses? I can hear fine, but easy to miss details during answers. If the lawyers just heard it. So that was an instruction to them. Judge says, move on. In your experience, does medical staff have a general sensitivity to direct, opinionated parents? No objection from Shapiro. No objection from Mr. Anderson. I do apologize. I'm not allowed to let you hear the audio, but I can tell you what I hear of the Zoom. So the Zoom audio is on, the courtroom audio is off. Next question. As a nurse, would you not want to chart disruptive behavior that a patient was displaying in her chart? As a rule, if it is not documented, it did not happen, ? We heard earlier that all Children's Hospital staff has nicknames for their patients. Can you tell me the nickname you had for the plaintiff? This is incredible. No objections. Red number 5. Nurse, are you attesting to this juror that by mouth or by personal message group or by official medical records that for 3 months, 90 days, only a select few had knowledge of, quote, ketamine girl, unquote? Yes, only a few. Confirming with all these, quote, team meetings, unquote, taking place to review patient treatment plans, no nurses or doctors commented on the possible validity of CRPS diagnosis and its serious effort to investigate Maya as having CRPS and treating for CRPS. Mr. Shapiro says, may we see the question, Your Honor? Okay, so this jury, we've got another one of, are you saying to this jury, this is crazy. I was supposed to wear wigs and change my voice as I'm doing this role play, but this is the best I can do. Shapiro says, we object to this question on several bases. Judge says, which one? Shapiro says, one is argumentative. Judge says, no, which question? Shapiro says, I think it's one question, or I read it as several. And judge says, I think it was several questions. Shapiro says, starting with testimony to this jury, it's argumentative. The question is asking for her as a PICU nurse, her opinion about what went on after her care. And then it asks what happens over the next 90 days. And it asks for her to speculate on the knowledge of what other people knew. Then it asks for the comment on what other doctors knew or suspected about the validity of the diagnosis. So based on all of those bases, we object to the entire sheet and foundation. Mr. Anderson says, to me, that sounds like a perfectly understandable questions based on the witness's testimony. Hughes says, but the witness testified that she had nothing to do with this patient after the first week. Judge says, well, it's asking about team meetings. That's fair. Shapiro says, the tone of the question is highly argumentative. Judge says, well, I can remove the argumentative language, but the question itself, though, needs to be asked. So I'll remove the argument testing language. Are you a testing language? Sorry. So I'm listening to the Zoom feed from court that we're not allowed to play the audio from. Judge says, okay, anything else? Anderson says no. Mr. Shapiro says 1 moment. The judge says different issue. And Shapiro says yes. Mr. Hunter says, I'm going to move to the back row to permit counsel to... Oh, I moved to the back row. I've become aware from a lot that's coming from the gallery. The lady just to the left on the back 2 row, there's snickers, there's laughters. There's a lot of commentary coming there that I think needs to be reined in. And if I can hear it, the jury can probably hear it. Judge says, well, I suspect everyone in the gallery just heard that. And if you're in the gallery, I would request that you refrain from making comments or commentary or laughing or snickering during witnesses' testimony, and ask the court deputies to keep an eye on it. Thank you. Let's bring in the jury. There we go. Okay, so that was, I try to give you everything I can hear. For practice for this, honestly, when I'm in the car, when I'm listening to a talk show, I listen, I just repeat everything I hear. And so, unfortunately, after doing all that, I can't tell you what I said, but hopefully it made sense to you a little bit. My retention's very low, but at least you got to hear it. My voice sounds a little bit better. It's all that hot chocolate I drank, I think, that did it. Thanks to Mrs. R.A. for that. Oh, I missed a super chat in here. Sorry. Oh, thank you. So, may I please pull up your recitation of these questions? Yes, Rob, 100%, anytime. Okay, great questions. Another set of great questions, very similar to what we had starting, I think, about 2 days ago from the jury.
Okay, please be seated, members of the jury. I want to confirm while you're away you did not discuss this case amongst yourselves, you did no investigation and received no information. Is that all correct? You didn't see any sort of media accounts of this case, is that correct? And no one approached you about this case, is that correct? Oh, let's go get the witness.
Bring the witness. She's sort of important.
I just want to prove to you we're doing this outside the presence of the witness.
The jury's asking for proof, so he proves it to them. We got another. Again, are you telling this jury? They're very confident in their identity and what their role is in here, and it's amazing. We've seen many trials where the jurors are allowed to ask questions, but never have we had a jury that's been so on point like this one is.
Okay, Nurse Klink, there's several questions from the jury. Have you ever worked with CRPS?
No.
Do you know how to work with CRPS patients?
I can't just answer that in a yes or no.
Well, explain what the best of your ability.
As a bedside nurse, as a bedside RN, our job is to follow the physician orders, and we treat as per order. So I don't go out of my scope of practice and do anything differently. I see what the vital signs are. I administer the medications. I take care of the things like her skin and things like that. I don't have a special, you treat them this way or that way. My job is to treat the patient as per physician orders.
Was Maya in any pain when she was cussing?
Maya did not say she was in pain. She would get very angry. She would get agitated. And I know kids can get that way if they're in pain. However, Maya was 10, and she was 10-year-olds would tell us if they're in pain or if something hurts them. Even if I ask Maya, or if you, it's like the pain scale, you can ask her, Maya, like, what's your 10, pain, are you in a pain of a 10? She would say, she can say I'm a 10 because she's 10 years old, but she never actually said, and I remember, she never said, this hurts, I'm hurting, this hurts me. My arm hurts, my leg hurts. She didn't say that. Oh, wow. And that's what I thought was so unusual, because a 10-year-old would tell you, younger kids would say, my leg hurts, my head hurts. But Maya never told me I'm in pain.
Okay. Did Maya calm down after she got her meds?
Yes, Maya would calm down after she got her meds. I remember she would go up and down a lot. Those meds are heavy duty. Those meds were strong meds. Anybody who is on propofol or ketamine is going to be pretty much knocked out. So, yeah, I mean, everybody, she would respond to pain meds.
Okay. As a nurse with 20 years experience, did you follow up with anyone if you had such a conviction that meant something, quote, my life is lies, end quote?
I think at that time I had moved from there. The physicians had known that because we had talked about that. Maya would shut down. I didn't have her again after that. It was hard to talk to Maya. Maya would kind of open up when she wanted to open up. I didn't ask her again. Things had started to become very difficult in the ICU. It became difficult. I didn't follow up, but I was hoping, because she was still there and they knew that the rest of the team would take over, but I wasn't her bedside nurse. And the ICU started to escalate in tension and stress, and it was no way to go back and to do that. And I just couldn't.
Okay, the statement, my life is lies, did you report that to a doctor to follow up on, or did you follow up at a later time?
I discussed that with the doctors. I think things were starting to, like I said, things were starting to escalate. Tension was starting to go up. They knew, and my job as a nurse is to report. That's what RNs do. We don't step out of that scope, but I did report. They knew, and everybody, I think that they started to see, well, yeah, couldn't move her legs, but she was all over the bed. So I think the pieces were starting to come together. But my job was to tell them that she said that, and I put it in the chart to make sure that it's in writing, that the team knows, and they were notified, and then they take over from there. As a nurse, I mean, that's not out of my scope, and I have to stay in my scope of practice, and the doctors take over from there for my reporting, and that's pretty much what nurses do. We are at the bedside the whole time, and we report changes because the doctors are in different places. We're assigned there, and we report things and then hand it off. But yeah, I mean, I wish she had finished that. That was shocking when she said that, and I wish I had the opportunity to do it, but there was nowhere for me to go from that, unfortunately.
Prior to working with Maya, how many children had you cared for with children with CRPS?
I don't know of any of them that had CRPS that would come into an ICU. I worked in ICUs, and so I don't know that they would probably be somewhere in the outpatient but I worked with kids that had pain, and that was my job, is to treat pain. So they could have neuropathy from chemo, they can be in car accidents and have trauma. So my job was to deal with the pain and not the diagnosis. They can have whatever diagnosis, but I'm there to take care of them holistically with their pain, whether or not they have leukemia, a car accident, or COPS. If they have pain, then I'm there to help them with that.
In response to the term inconsolable, when you say these are various options, do you have the option to free text?
Yes, I do have the option to free text. At the time, that was the first day that she came in, and there was so much going on in the beginning with the medications and the yelling, and the tension was rising. I didn't go back and free text. That would have been a good idea if I did. In hindsight, I should have free text, but those were the options, and there was just so much coming at me that day. I couldn't go back and start changing things because ICUs are stressful. They're intense. That's why they're intensive care units. There's alarms. There's all kinds of things going off, and we're used to that. This was way above and beyond in the level of stress and the yelling. They were swearing. I should have free texted and said what I meant. I didn't, but there was just so much coming at me. It was hard to even stay afloat.
Do you remember the position of Maya's feet on admission?
No.
How many residents were in the PICU on that night?
That night, I was working on the day shift. There would have been one resident that would have been assigned to her. I don't know which night they're referring to, but I worked on the day shift. And when there were the residents in the room when that incident happened where she cursed at Dr. Teppa, that's when there were multiple residents. There was probably 2 or 3 residents.
During your 12-hour shift, how much is rotation? How much is spent documenting?
We spend a lot of time documenting. The amount of documenting that we do on an admission, we are clicking through pages and pages and pages. It is a lot, and you just try to stay ahead of it. Meanwhile, you're getting orders that are coming in and they're changing. The orders are going up, they're going down, but do this, you're doing that. So we spent in the beginning, there could be several, I would say 2 hours on an admission of just doing the whole admission profile. There's a lot of questions. Do you have a dog? Who lives with you? There's just so many, and I think that's where I got tripped up by not maybe going in and doing some more documentation, because I'm responsible for all just the basic stuff that comes in, and there's pages and pages and pages. And then I have to take care of the patient. So after the patient gets settled in, like that next night, that next day, it gets a little easier because all that intake stuff is very intensive to complete.
Have you ever had other kids in extreme pain use curse words?
All the parents here listen very carefully. This should not be a 10-second think about it question.
Maybe it's not really, not that much, really. I think not that often. If they're in pain and I see that it's matching up with the monitor, and I could see that there's pain issues, I could see their heart rate is up, their respiratory rate is up. Like I said, I'm very serious about a child's pain. It doesn't go to the point where somebody's swearing that they want pain meds, because I see they're in pain and I act on that. That was always one of my things, is making sure that they're not in pain. I'm not going to wait and say, oh, I'm not going to give you the meds, wait until I'm done. I act on pain quickly, so it doesn't really happen, and it doesn't really escalate it to that point. And to swear, and it was more of, I wanted my effing sedation. That again is as a nurse, I'm looking at it like, she didn't say she was in pain, and she didn't look like she. So that's not. It doesn't typically happen that they swear when they're in pain. It could, but it doesn't typically happen. They get their pain meds when they say, I'm in pain.
In your experience, do medical staff have a general sensitivity to direct, opinionated parents?
I don't know what a direct sensitivity for direct, opinionated parents, but I think all of us we have all kinds of parents that come in. Direct, opinionated is completely fine. You are an advocate for your child, and I'm happy about that. I think a lot of us have that kind of personality where we have a strong personality. You have to be in an ICU, and I'm not sad over it. This was not that. This was way different. This was very demanding, and the curse words were like kept coming. This was different. There's many parents. Parents are very protective of their children, and they advocate, and that's totally cool. That's great, and I'm there for that. This was not a direct, opinionated. This was the ICU had become toxic, and that's a lot for an ICU nurse who had been there 16 years in ICUs. This was not like other ICU admissions, and so no, we don't have a problem with people who are direct.
I'm watching the defense attorneys right now, and their body language is hilarious.
Would you not want to chart disruptive behavior that a patient was displaying in her chart?
I would chart disruptive behavior. It's now, when we're looking back, I had Maya just in the first. All this stuff was in like the first. Hours of admission, half hour. I had no preconceived notions. I didn't have any background to think, oh, well, wait a minute. There's patterns that's starting to form here. This was like completely a blank slate. I didn't know about any of this. Maybe after time would go on, I'd be like, I better put this down. When Maya said my life's a lie and I'm tired of all the lies, then I did start charting, because I was like, whoa, there's something going on here that needs to be looked at, and I need to tell, and I did. And that is when it started. But in the beginning, I had no preconceived notions. I took everything at face value. And then things started to happen, and then you look and you're like, wait a minute, things are not what they seem to be. Something's going on here, and it needs to be looked at.
Next question. As a rule, if it is not documented, it did not happen, ?
So in nursing school, and we are drilled on that, and that is true. But that really speaks to, did you hang this antibiotic? You can't say, oh yeah, I hung this antibiotic, but I didn't chart it. It's for the patient stuff that you do. If you didn't, like I said, give this med, if you didn't do this bath, that kind of stuff is there. If you didn't do it, it's not done because you didn't chart it. This is not the same. This is what somebody else is doing. We are not expected, and it's 12 and a half hours, and all of this stuff is going on. I can't chart all of that. So it's not an expectation, at least it wasn't then, and it probably isn't now because it's 12 and a half hours, to document what other people are saying. That's different. It's not like hanging the med. Did you give them a bath? Well, if you didn't chart, you gave them a bath, then you didn't do it. Those are two different things. That's what I'm responsible as a nurse to perform those duties.
It's not my job.
That's what that is. So that part is true. Documenting what other people say, that's not in that realm of my responsibility. When Maya said my life is a lie, I'm tired of all the lies, that I thought I needed to document that, because that was something above and beyond. But typically, no, we don't. And like with Bea, no, I wouldn't put that in the chart. That's not what I did.
We heard earlier that all Children's Hospital staff had nicknames for their patients. Can you tell me the nickname you had for the plaintiff?
I can say absolutely that's not true. I've not heard of nicknames for patients. I've not heard of that. I did not hear any nickname for Maya at all. I don't even know. I don't know if I've ever even heard that people have nicknames for patients. At least not. I never hear that in the ICU, and I haven't heard it on any of the ICUs where I work, where people's like, oh, I call him this thing, I call him this. It's usually somebody will say something. If there is oh yeah, I have 554, meaning I have the kid in 554. But people don't. I've never heard people make up nicknames on patients.
She's about to hear. That'll be on
Are you
cross.
saying that either by mouth or by personal message group or by official medical records, that for 3 months only a select few had knowledge of, quote, ketamine girl, end quote?
That sigh.
I don't know about what everybody else knew. I don't know. From hearing that, sometimes there's so many kids that come in, and if there's something that is very distinctive about a patient, somebody will refer and say something about, just so you can remember who this person is. I don't think it's done derogatory, but you have to have some way of remembering there's 29 bed ICU. Sometimes we float to the other units. It's hard to remember, oh, this is John Smith. And of course, now we remember Maya, but that's only because of all of this that happened. Sometimes you have to come up with some way to say, yeah, this was, whatever, to designate who that patient was, but not to be derogatory. It's just, somebody's not going to remember, Susie Smith. It's hard. Some kids have, similar names. So sometimes, from hearing that, I think somebody may bring that up as a way to identify that person. But no, I don't think people don't have derogatory names for that. Just so that people, I think that's what that is.
With all these, quote, team meetings, end quote, taking place to review patient treatment plans, no nurses or doctors commented on the possible validity of CRPS diagnosis and a serious effort to investigate Maya as having CRPS and treating her for CRPS.
Well, I think, actually, I know, the ICU had the diagnosis of CRPS. I think that they went with the diagnosis of CRPS, but the thing is that you have to treat this child. So if she's in pain, you have to treat her pain, and I think that that's what they were doing. I don't think that the ICU, because I can only speak for the ICU because I was there. I don't know about the floors, but the thing was to treat the patient. The meds, those drugs that were being demanded are heavy-duty drugs. Like, you don't see people on these drugs. That's a big deal. So I think they wanted to treat her CRPS in a different way so that it's safe for Maya and start to bring the drugs down. You can't have a 10-year-old in a ketamine coma and on propofol. I mean, that's the drug that Michael Jackson died with. I mean, it's a heavy-duty drug. It's complete sedation.
Your Honor, on pure speculation and also not responsive to the question.
Well, sustained is not responsive to the question.
I'm sorry. I didn't mean that.
Strike these comments.
I think the
jury's going to disregard the lengthy response that was not responsive to the question.
I'm sorry. I think the ICU was trying to do CRPS in a safe manner for Maya, and treat her CRPS, or treat her whether it was CRPS, but do it safely.
Any follow-up from the defense?
Just one. Nurse Clink, have you ever told anybody that Beata Kowalski was crazy?
No.
Thank you.
Plaintiffs.
Can you see why your description might make some of your compatriots think that's what you meant? Now, could you see that?
No, I don't understand. No, I cannot.
You said, you quoted, "My life is, full of lies," or "My life is a lie." What is you saying?
I didn't say it. I put in a quote.
Right. Now, you're trying to interpret that here for the jury, are you not?
I put it in the quotes for a quote, so it's a quote.
Are you aware of the fact that CRPS patients constantly have their diagnosis challenged? Do you know that as a nurse?
Objection, foundation.
Overruled.
I would imagine so.
And that a 10-year-old child having a doctor, a nurse, a social worker, a doctor, a nurse at different places tell them that they don't believe her, she might actually say something like that?
I don't know what she was thinking.
Well, okay. But can you see how, from Maya's point of view, being told at another hospital, different hospitals, maybe at Johns Hopkins, that there's something wrong with her symptoms, she might in fact feel as though everyone was making out her life as a lie?
Objection, calls for speculation.
Sustained.
He doesn't need an answer that
No,
way.
I sustained it. You don't have to answer.
The jury got the point.
So now, you saw Maya for the first, I think you said 30 to 60 minutes she was in there?
Yes.
And not after that?
No,
Did you see her after that?
Yeah, I was with her that day.
So when you say there's a pattern forming, are you forming a pattern from the first 30 to 60 minutes of this girl's life?
I think as an ICU nurse and as people, we start to put pieces together for everything. So yes.
Where did you get your degree in psychology?
I think as...
Do you have a degree in psychology?
I sustain the objection. What's the next question?
Okay, sit down. Mr. Anderson, you've been effective. I think you're done.
Well, what I'm asking is, it's interesting, don't you think, that none of this ever happened again, that it was never documented again, despite a 3.5-month stay?
Objection, argumentative, and misstates the facts in the record.
Well, those objections I'm going to overrule.
So can you ask the question again?
It is unusual, is it not, that none of this type of behavior was ever documented by anyone else the rest of her 3.5-month time at Johns Hopkins?
Objection, foundation.
True?
Sustained.
Having not followed her, you would not know whether this ever happened again or not, would you?
I would not know.
And are you aware that, in fact, Maya was checked out after this by a pediatric psychologist at Johns Hopkins?
Objection, foundation.
Do you know?
No, I after she left, no, I don't know.
Okay.
This witness is so nervous. She's like, what, deer in the headlights right now.
Have you ever reviewed the Johns Hopkins Patient Bill of Rights?
I believe in the beginning, yes.
So when Beata Kowalski was telling you that she did not agree with your methodology of treatment, she was well within her rights?
I can't answer that.
And neither can you answer to know what you're describing means for Maya's overall psychological health or otherwise, correct?
Foundation, compound,
overall.
Can you repeat the question?
Sure. Based on your 30 to 60 minutes, you have no idea how anything you testified to really has anything to do with Maya's sociological or psychological makeup. True?
In those 60 to 90 minutes, I treated the patient based on physician order.
I'll take that as a yes.
objection, argument.
You can answer the question.
If Maya had CRPS or anything, I would have treated her the same way. I would have, yeah.
If Maya had, I would have treated. She doesn't believe it.
That's all I have
at this moment.
Anything further?
They are.
See if the jury's done.
Jury members?
Yes. Yes. One of the female witnesses has said yes. Our field of jurors has at least one question for her. I'm sorry about the noise. The mics they're using are awful right now. I'm going to see if I can switch some sound up here. Just 1 second. Okay, we're going to listen in case... well, they've got the... We're not going to be able to hear this. They've got the white noise on. There's Jules. I cannot wait to hear what Jules has to say about this. Yeah, they've got the sound turned off completely, so we're not going to hear this on the Zoom feed either, unfortunately. Hopefully all the questions get approved and we'll get to hear them asked to the witness. But, oh my goodness, the setup. Do you see the setup the jury had with those the 1-2 punch questions where they said, what was your nickname for Maya? And she's like, we would never do that. We don't do that. None of us, that's not something we do. Like, well, we know you did. So are you saying that no, you didn't know? Oh my goodness. The anticipation of her answer. This is literally, we must have a lawyer. Okay, we've got a lawyer on the jury because they're so good at this. I got a little comment. I won't out who sent it to me, but I got a little comment during that and texted to me and it said, I've never watched a ship sink in real time before. And I had to chuckle because, wow, this is incredible. Let's see. I want to switch to a different, I'll switch to here. No, we're going to switch to here. I've got, my feeds aren't synced up right here, so I've got to just match them up and see where we're at. Got to wait for something to change. Okay. No, we're good. We're going to go here. All right. I do apologize for the slow mode. I realize there's some of you that, because of the type of account you're on, you're not able to become a member, and it really cramps your style. We want to have conversations, but it times you out. The chat is going so fast. We've got 2,600 people in here. If we could ask the chat to sort of stay focused on this and try to limit our conversation. I'd like to keep that slow mode timeout much lower than it is right now, just so we can focus on this. And allow people in. Rob says, not a lawyer on the jury, but retired law enforcement. Yes, also trained in how to question. We've got a trained interrogator, okay? Somebody from the FBI or something. Seriously, we know we have somebody who has major, at least some nursing experience. They're literally quoting what they were drilled into their minds in meds, as they were going through nursing school, about if it's not charted, it didn't happen. We've got people with experience in this field that are sitting on the jury. It's just, oh man, this is just wonderful. Bug Dugger just gifted another 5 memberships. Thanks for your generosity. That's so cool. Thank you very much, Bug Dugger. You've been generous over and over again. According to Woo, also gifted 5 before. Thank you very much, Julie. Thank you for your super chat there. It was a little bit back a bit. I'm just trying to catch up. I'm way behind, and I'm sorry. Let me tell you about the body language for the defense during that. I was watching the Zoom, and the Zoom was one of the videos was focused at the defense table, and Mr. Hughes was sitting still as a statue, not moving. I just it looked like a deer in a headlight. When you scare a cat, it's like not sure if I should run or fight type thing. It was that. It was just frozen, did not move. I mean, did not flinch. Everyone else on the defense table, hands together, and they're staring down at the desk. There's no writing. They're just staring down, fidgeting. Just looking down. It's like, oh my goodness. Oh my. Let's see what these next questions bring. Every witness from this defense has such an adversarial attitude except for one. Seriously, it would go so much to her credit just to answer the question and let it get fixed later.
Next question from the jury. So instead of using her room number in a conversation, are you saying, quote, ketamine girl, end quote, is an appropriate way to describe Maya?
I can't say it's an appropriate way, no. I didn't use that term. I can't say it's an appropriate way. I don't know the context of it, and I don't know if it was to say, hey, this is the one I'm referring to. But no, it doesn't sound nice. Again, I don't know the context, and it probably should have been a different way of referring her, and maybe they get into the habit of trying to use that as identifiers, and they should probably move away from that. It's probably not very nice.
The next question from the jury. Do you think Johns Hopkins All Children's Hospital should have trained all personnel working with Maya to give her proper care and help staff treat her?
I think that we were treating her, we were treating Maya with dignity. We were treating Maya with respect. We were trying to take care of her pain. That's absolutely true. Whether or not, I think they kept it open and accepted, okay, she has CRPS or any other differential diagnosis, but I think that in the ICU, at least I speak for that, we were treating Maya with her pain, whether it was CRPS or whether it was something else. If she's feeling pain, it needs to be treated. And I think that's what they did, or were trying to do.
You had mentioned that you may not be well versed in CRPS back in 2016 during the Maya times. Is that correct?
Again, it's the same. Yes, I wasn't well versed in CRPS. I started reading about CRPS when she started coming through, and I was learning about it. But again, still, we're there to treat Maya. At least from my point of view, we're treating Maya for her pain and her taking care of her needs there, whether it was CRPS, whether it was like neuropathy, nerve pain, or leukemia, we treat Maya for her pain and go from there. But whether it doesn't matter, at least I shouldn't say it doesn't matter, but we had to treat Maya for Maya. And if it was CRPS, then it was CRPS or neuropathy or whatever, but treating her pain. And that's what I think that they were trying to do.
The next question, did it ever cross your mind that because Maya was, parentheses, as said by past witnesses, in parentheses, more mature than a usual 10-year-old, or that having gone through this pain before, she would have expressed or handled her pain differently? Did that cross your mind?
Yeah, I think about that. And I think if kids know their medical conditions, and if you give a little kid a blue medicine and it tastes terrible, and the next time you come to them with that blue medicine, they're going to cover their mouths. They know what the deal is. And that's why it was unusual. It didn't make sense that Maya was saying, I want sedation. I want my effing sedation. Like, she didn't say, oh, here's where my pain is. This is where I normally have pain. And that's what kids will do when they come in. They'll say, yeah, they have issues with, head, or, yeah, my issues are really usually here. I usually have my back aches here. But that was never any of that. And that was very unusual. Kids know what has happened to them in the past. And then they tell you, I didn't have any of that. I didn't see any of that. And that was when I was surprised that she didn't convey, hey, my pain is here. Because that's what kids tell me.
Okay, the balance of that question I can't ask. Okay, that concludes the juror questions. Are there any more questions from the defense? From the plaintiffs?
No. Thank you.
May this witness be excused?
Yes, Your Honor.
Okay, thank you, ma'am.
And here's another 25-yard dash.
Members of the jury, I think this is a good time for our afternoon break. Let's try to keep this to 10 minutes since you all have already had a stretched break. We really haven't, so let's try to keep this to 10 minutes. Do not discuss this case amongst yourselves. Do not do any investigation and receive no information.
Okay, this was so much fun. Rob, I'm so glad you're here. I cannot wait for tonight. For those that don't know, Rob from Law and Lumber is watching in between working. He's a full-time lawyer, so he's in his spare moments. He's trying to catch up on the trial, and he does just amazing recaps at night. I can't wait for Rob's take tonight. If you have not subscribed to Law and Lumber, please do that. It's well worth the watch, even if it's late at night. I'd recommend a rewatch on his take tonight. It's good.
I just have a real question about it.
Sure.
This Mystica is another DCF type employee. She has requested to appear by Zoom in the afternoon. The request has been presented. The other side doesn't object. I just want to ask the court if that's
There is or is not an objection?
There's not.
And where is she located?
She's in Bradenton.
Okay. And what's the reason that
She advised that she has therapy patients and she would like to not have to rearrange all of them.
Then, yes, but you need to get with Ms. Syback.
We did. The second half of that, Judge, is the DCF attorney would also like to appear by Zoom. Is that acceptable?
I don't think so. It's not acceptable to me to have somebody there where we can't keep an eye on what's going on.
They'd be in they're not in the same room. They'd be in different offices. But I had to ask. They asked me to ask, Judge. So.
Well, if they're different locations.
They're different locations. They're not going to be in the same room.
Yeah, but I just think it's a little different than having your lawyer and the personal lawyer in the veneer versus, I mean, out in the gallery rather than up there next to you.
They're not going to be in the same room. I think the DCF lawyer is actually in Tampa. They're not going to be in the same.
Is it a DCF lawyer?
DCF lawyer. That's what I'm saying. They're in Tampa. They're not even in the same city.
Let's just have them come by Zoom.
Okay, thanks.
Judge
I'll get that email to you.
We'll try to take less than 10 minutes.
Okay. All right. My ears are killing me. That we've had problems. We had one of the jury questions that was presented was not actually a jury question. It was actually a request to the court. Specifically, they're saying they're hearing noise. They're hearing snickers. They're hearing laugh. They're hearing probably a little bit of whispered consultation. The microphones at the defense and the plaintiff's table are incredibly sensitive. They're probably what's called a condenser mic. It can hear a pin drop. Okay, it's just they're very, very sensitive. And so you've got these attorneys that will lean back. This is a dynamic mic, right? So if I move away from it, you just can't hear me. You just can't hear me. It goes away. If this were a condenser, I could stand on the other side of the room and you'd still be able to hear me a little bit. So the mics they have are very sensitive, and they've been doing a little bit of really, type comments and like, oh, that's not true. We're getting those little whispers, and I can hear them when I'm wearing headphones. You guys probably hear it if you've got the volume up. The jury's like, hey, can you guys knock it off? And they didn't call out one side over the other. They said, can you guys knock it off? That's distracting. We want to catch every detail, and we don't want to miss anything. And so during that, then following that, Mr. Hunter says, hey, by the way, I've been sitting on the back row, and it's coming from behind us. We've got people in the gallery that are snickering and talking and whispering, and they even pointed out a section on the back row or something they think that was involved in it. Anyway, the judge says, well, you guys, everyone's heard. That's going to stop, and he instructed the bailiffs to stop that as well. This is fantastic. This is so good. Oh, man. Yes. Let's see. I have heard the judge said he was going to split the time between the parties, but then at the same time, the judge this morning gave each side 4 extra hours because the jurors had been asking a lot of questions. So in a way, he refunded the juror time to the two sides, so it's not charged. So I don't know how that's going to continue. This has been a lot. Today's been a lot of jury questions as well. So it's possible the judge might, allot another extra hour or two to both sides as this goes on if the sides get close to running out. Not sure how that's going to go. The judge will take care of it. It's not going to be a problem. Why is Sanchez beside the defense table? Was she released from subpoena? I don't know, but she today is the visiting doctor, and they've done this every day in court. If you think back to the very beginning of the trial, right before opening statements, the defense objected to having Kyle Kowalski sit there because he's a witness, and they said we want to exclude him, and the plaintiff said, well, then we want to exclude your medical doctors who are just sitting next to you on the stand. Some of them are witnesses as well, and they negotiated and said, okay, if you allow our rotating doctors to sit with us every day, then we'll allow the other, and they did. So every day the defense team has had a doctor, a representative from the hospital, Johns Hopkins Children's Hospital, sit there in a show of support and be able to participate, and that's what we have. And today it just so happens to be her. It might be convenient because she was here testifying anyway, so it might be she had had that day blocked off just for this. But we've seen doctors with them, and usually they're introduced at the very beginning of the day. The defense will say, and today our J Hatch representative is Dr. So-and-so. All right. Where else? What else do we have? We've got a little bit of a break. Can a mod drop Rob's channel link, please? Please do that. It's Law and Lumber is the name. It's pretty easy to find, but a link can help as well. There it is. Thank you, Amber, for doing that. And let us know if that link's not working properly. I think that goes straight to... That might be his channel page. I think you can just stop at Lumber, and it will get you there as well. Just youtube.com/@lawlumber. Peter Steele says, a bit left field, what are mics that are big, round, and perspex they use on FNL? Oh, okay, you're talking about the little dishes that are held, like a parabolic dish. I actually had a buddy who did that job, and it pays really well, actually. You basically take that, it's like a listening device that, using the parabolic dish, funnels sound from a certain direction into the microphone, and that's, if you're watching NFL or football and you hear the quarterback, calling out to the players, and you hear the pads hit when they hike the ball, that's the microphone that picks it up. It's basically a directional mic that can really just pick out sounds from a certain area. I don't know if it's dynamic or condenser or what. I'm not that familiar with them. link worked. Wonderful. Thank you, Samantha. Appreciate that. Okay, I'm sure the family wasn't perfect and made mistakes, but the defense seems to be suggesting imperfection is a reason to discount Maya's case. Not a good route. People, for real, I think we are, we're still very, very early in the defense's case. And I think we are going to have some very good witnesses for the defense. Some witnesses that come in and lay out evidence that really does back up some or a large portion of what the hospital claims it did and the reason why it did it. Obviously, some of that will be disputed a little bit, but I think we are going to have some witnesses that will cause all of us to stop and think, well, maybe I need to rethink this portion of how I feel or where I stand, because I believe what I'm hearing right now, and it's different than what I knew before. So we've got a couple more weeks to go over all this for the defense. So don't go anywhere. Hold the phone. Buffer on hot mics for the for Zoom. Yep, it's counsel communication, so I'm not gonna recount that. If the counsel's talking to each other. I realize that it is an open court, and anyone in court can hear that. Maybe Jules will be able to report if she hears. I think Rob's going to hit 200,000 tonight. He is so close. I think last night he was like north of 197,000. Let's see. There's always two sides, yes, and this is what we love about court. This is why we like this adversarial system. There are two sides to every story, and there's a case to be put on by the defense as well, and they're going to have some good points, and they're going to have some not so good points. We've had a couple of the not so good moments just recently, and I think this last witness was one of them. Initially, when she started, it was not good for
to say a witness is lying. It should be okay to say Maya is playing into her mom's suggestions, ideas, off treatments, etc.
If it's okay to say a witness is lying, it should be okay to say Maya is playing into her mom's suggestions, ideas, or treatments. I would just couch it in how you feel, okay? Because we're not going to we had one juror question that came in that had. The question was written in such a way that it presented that juror's opinion. And the judge said that was not an appropriate way to ask the question, and he ruled that part out, just like that. So if you want to say that, you'd say, I don't think she's believable, or to me, she's not believable, something to that effect. But I appreciate you guys being fair and respectful in chat. Yes, they said that would be done by November 1st, so we've got 10 days left, a week and a half. Okay. All right. I missed a lot of chats, and I apologize. A couple super chats came in and messages. If I missed that, I do apologize. I do try to recognize them all as they come through. But I just want to say thank you. Thank you very much. Thanks to all those who are gifting memberships, to the new people who are coming in and finding us now. Thanks to all those who just like the stream. That allows YouTube to do its thing and help other people who might be interested in this as well find the channel. And that helps me. So it's a free way to help me out. If you feel inclined, I would appreciate it. Objection-wise, we're at 11:44. Let's check our scoreboard here. Detect vids. It looks like we just passed you at 11:43. Looking ahead, if we can, we'll see who's coming up with their guesses and where they're at. Imagine we'll probably be past. I don't know. It's a depot coming next, and depots oftentimes they've got all the objections cut out. So, and I don't want to count it just because there's a cut or a splice in the tape, because it could be somebody just asking for a break, or hey, I need to go to the bathroom, or I need to refill my water, or I left this in my other office, I'll be right back. It could be a million different things. So I have not been counting every break in the deposition unless we can clearly hear somebody say objection or grounds or form or something like that. Those ones I'm going to try to count. If I miss one, just let me know and just put in chat, 11:45 or something, just so I can see that, and we'll try to count this together. Keep me honest on this if you can. Anyway, that's how the next few people in the poll are going. We'll rewind a little bit to where are we at? Right here. Detect vids. We've got you as the closest right now. We'll move on here from a moment. Okay, there are 3 sides to every story. Why not go with 4? Let's make it nice and even. Let's see. Amber says, no, it's Anderson and Whitney talking to someone in the gallery about random stuff. Haha, we're men. That's what we do. We get in trouble. Oh, it sounds like they're getting in trouble now. I'm not going to out them in that. On Zoom, it looks like counsel's returned to the tables now. Judge is not back in the courtroom, so it's going to be a few more seconds at least before we return. Let me get my feeds lined up.
Saying hi and applauding your great work.
Andy Logan, thank you very much. Appreciate it. Good to see you. Yellow Courthouse by your name. Longtime supporter. I appreciate you here. And thanks for the super chat.
Everyone.
Here we go.
I know we don't need to bring the jury in. I think they've got a change in plan, but
we do. Oh.
We're going to
Shapiro's like we do.
Kornberg instead. We are wondering about Detective Graham tomorrow.
You're packing your bag.
Well, he doesn't want to stay for the
realize
presentation of Dr. Kornberg for reading.
He's about to abandon me, but before he does so, we'd like to have a discussion about one of their witnesses tomorrow so that he can leave. Just what's going on.
And I thought we were going to do the discussion, Detective Graham, after we let the jury go home for the day.
I think I'll stay. You know,
it's probably an hour. I'll read fast.
All right.
Okay. I will read loud and slow.
Judge, to be clear for the record, we are not calling our next nurse just because of the time, so we're going to read the deposition of Dr. Kornberg. Unfortunately, there's no video, so I'll play the part of the attorney, and
we're back in acting class. We're back in acting class.
Okay, well,
hope you brought your popcorn. This is the good
remember,
stuff.
you got to do different voices.
We have different voices.
Wigs.
You got some wings?
You got the wigs.
Okay.
Are we ready to bring in the jury?
Yes, sir.
Yes, sir.
Okay, let's bring in the jury.
Lisa, thank you very much. We've got quite a few people here who came over from Lawn Lumber. Welcome, all of you. We love Rob. Our communities are very similar. So thank you so much for being here.
That's okay. I was going to give Miss Lawrence your seat.
I'll take it.
There's never a dull moment. Okay, so what you're going to see here is going to be a little confusing if you just stumble in. We'll probably have, in just a few minutes, an attorney sitting in the witness box. And everyone's going to be like, hey, wait, what? Wasn't that? Yeah, the attorneys are going to be reading stuff. I think we're going to have one in the witness box. One will be asking questions, and they may be voicing questions from someone who is not themselves.
Okay, please be seated.
So just buckle
Members
up.
of the jury, want to confirm
We'll try
while
to
you're
explain
away,
it
you
as it
did not
happens.
discuss this case amongst yourselves. You did no investigation and received no information. Is that all correct?
Correct.
And no one approached you about this case. Is that correct?
Correct.
And has anyone seen any media coverage about this case? Ms. Croyles, call your next witness, please.
Yes, Your Honor, we're going to call Dr. Paul Kornberg, MD, by deposition.
No wigs, but different voices.
So we've got Dr. Kornberg.
Deposition taken on November 20th, 2019.
I really like Shapiro reading. He does a good job on this, so I think he'll do great.
The witness, after being first duly sworn on oath, was examined and deposed as follows. Could you tell us your name, please, sir?
Paul Brian Kornberg.
And what is your occupation?
I'm a physician. I specialize in physical medicine and rehabilitation.
Tell me, well, let me kind of ask you a few questions about your background and training. Where did you go to undergraduate school and medical school?
I graduated from the University of California at Berkeley in 1989, and then I attended medical school for a year at Albert Einstein College of Medicine. And then I trained at the University of Miami because my wife was a student down there. And I graduated with an MD in 1994.
And where did you go from there?
After medical school, I was in residency program at Baylor College of Medicine in Houston, Texas. That was a combined residency of both pediatrics and physical medicine and rehabilitation, so a 5-year program. I completed that in 1999, and then I earned a master's degree while I was there in rehabilitation technology. And that's when I completed my training. And then I got a job after that.
And your job was here?
Actually, no. My first job was at Eastern Virginia Medical School as an assistant professor in the Department of Physical Medicine and Rehabilitation. And that was in Norfolk, Virginia. And I was there for about 3 years. And then I came here in July 2002. And that's when I took a position with this group.
And are you board certified?
I am board certified in physical medicine and rehabilitation.
Are you board certified in pediatrics?
I'm not anymore. When I was initially, but I didn't renew my certification when it expired after, I believe it was a 7-year certification.
And do you hold any academic appointments presently?
I'm officially an assistant professor of physical medicine and rehabilitation at the University of South Florida.
And what medical staffs are you a member of?
Which, like, hospitals am I at staff at?
Yes, sir.
I'm at medical staff at St. Joseph's and St. Joseph's Children's Hospital of Tampa, where I'm the medical director of pediatric and adult rehabilitation. I'm on staff at Tampa General Hospital, where I'm the medical director for pediatric rehabilitation, and I'm also on staff of what's now Advent Health Tampa, although without any fancy titles.
What is the scope of your practice here in Tampa?
Well, as a physiatrist, or physical medicine and rehabilitation specialist, I work primarily with children and adults because of the nature of our group, with a focus on rehabilitation medicine, trying to help people be as independent as possible as they can be in their lives, trying to help reduce complications that we know they may be at risk for due to their underlying conditions. Trying to, in physiatry, there's a broad scope of things that we might also address other than function. Sometimes it has to do with musculoskeletal pain, injury, rehabilitation from injuries, or things of that sort. So I work with a variety of different types of diagnoses. And I work with, ages from infants to geriatrics in a variety of manners, seeing both patients in the outpatient setting here in this office, and I also have a clinic twice a week at St. Joseph's Hospital. And then I do inpatient care where I perform consultations at both St. Joe's and Tampa General Hospital, and sometimes at Advent Health. And I have a patient population at Tampa General Hospital that's admitted under my care for an inpatient intensive rehabilitation to, oftentimes that's a child that's recovering from some sort of injury or illness, rendered them less independent than what they used to be at their baseline.
Do you have occasion to treat patients with chronic regional pain syndrome? I
do. It's not something that I see commonly, but I'd say it's something that I've seen over the course of my career, probably maybe on the average one to two patients a year, something like that.
You see that in the pediatric as well as the adult setting?
Yes. I do more work with children, so I would say I see that more with children.
Okay.
Because of the nature of that population. Of the nature of that population that I serve.
We're here today about a patient by the name of Maya Kowalski.
Yes.
Do you remember her?
I do. I do remember. It's been, I think, 4 years or so since I've seen her, but I do remember her case to a degree. I would obviously need to rely on her records to help me, but I do remember a bit of the time we spent together when she was at the hospital, at Tampa General Hospital, for inpatient rehabilitation.
What is your role at Tampa General Hospital? I guess you work in the rehabilitation center?
Well, the rehab center. And let me know if I'm talking too fast because I have that habit. The rehab center is really geared towards adults, so for children that need inpatient rehabilitation, we do that within the General Pediatric Medical Center. So it's in the general pediatrics area of the hospital. Then we receive the same types of services, but it's in more of a family-oriented environment where we have pediatric nurses, child life and playrooms, and teachers and child psychology and things like that. So my role there, rehabilitation, is a team sport. There's a lot of different specialists that are involved. And part of that rehabilitation often, and it depends on the needs of the child, or the adult in that case, but oftentimes there's a variety of team members that include physical therapists, occupational therapists, speech-language pathologists, nurses, psychologists, social workers, child life therapeutic recreation, and sometimes there's also an additional medical specialist that are involved as well. So as a physiatrist, we're kind of like the team leader. We kind of look at the big picture and try to help out with the coordination of the care for the individual. In the hospital, I'd say that's the kind of role that I play. There's a lot of people that help to achieve our goals, and I try to help coordinate in that process. But at the same time, as a physician, I sometimes will do diagnostic testing or prescribe medications or prescribe specific treatments or consult other specialists or other physicians to help in the care of a child.
Page 13. Were you her admitting physician?
I was her admitting physician. At Tampa General Hospital, I have the benefit of working with a nurse practitioner. At the time, it looks like Bonnie Rice was a nurse practitioner on my service working with me closely. So as you see her name on here, Bonnie performed. Usually, the nurse practitioner performs the bulk of the documentation. Then I add into that. Sometimes, if I'm not around, my partners will cover for me. So there should be a physician involved every day. But I was involved in the admission process as reflected in the notes here from her admission history and physical dated July 30th of 2015.
So would you have gone over, well, let me back up. You said Ms. Rice is the ARNP. There's ARNPs on the service?
She is she's the ARNP that works directly with me in pediatric rehabilitation. So she would be, stationed at the hospital all day and seeing the patient as kind of like a frontline contact, where I'm there every day for portions of the day, but I'm also running to other hospitals and I'm usually doing clinics. Usually at that time, I was probably doing clinics 5 days a week. There were times, this was a little bit of there were other things. I'm not sure if I was around all of the time, but there were other things going on outside of my medical practice that took me away from work for a little bit. So I'm not sure if there were other doctors covering, but she was stationed there as a full-time job. So she was the most directly involved with the patients.
So she would have taken the history and done a physical, and then you would have replicated that? Is that what I'm understanding?
Well, I go through the same process. I review the records. I review information. If there's family that can provide additional information, I'll tend to go over those things as well. I'll review records before a child is admitted to understand what their situation is, to the best of my ability, and to see if they seem appropriate to even bring into an inpatient rehabilitation setting. So that's part of the history gathering. It's both the review of records, communication with the family, communication with the child, if they're able to provide history. And then I perform my own physical exam as well. I don't document everything all over again in redundancy, but whatever I've commented here, you can see how well it correlates with what I've documented.
Well, let me just ask you, generally, what history you took when you admitted Maya on, I think it's July 30th, 2015.
Well, the history as reflected in her admission note that I signed off on and amended, reflected that she had previously been treated for asthma exacerbation, had been treated with several courses of steroids in the few months preceding her admission. She had multiple trips to the emergency room at All Children's Hospital, and she developed weakness subsequent to one of those treatments with steroids. And the symptoms resolved over a day or 24 hours. And then she was admitted to All Children's on July 7th for what appeared to be another asthma exacerbation and was treated again with steroids. And then she had increased weakness, had been evaluated by neurology, and had, again, this is a summary, of a lengthy hospital record and potentially other information. So I'm sure there's more to the story than all of this. But there was a diagnosis of steroid myopathy that was entertained. I don't know that was something I personally was able to confirm, but that was the history presented to me. She continued to have significant weakness and pain and was having difficulty, functioning, performing normal activities for a child her age, which eventually brought her into the hospital with me for rehabilitation. And then it looks like she was seen at some outlying hospitals too, up in Chicago, and was being treated with steroids due to adrenal insufficiency and hydrocortisone. So again, I'm just kind of referring to the documentation here.
The history suggests that she had a normal CPK. How is that significant, or is that significant in terms of a myopathy diagnosis?
Usually I would anticipate CPK is an enzyme that's released from the muscles when they're inflamed or damaged. So I would think if you have an active myopathy, that you would see an elevated CPK. And I'm certainly not an expert in the diagnosis of myopathy. And I'm not sure what, the sensitivity or specificity of a normal CPK is, if that would exclude a diagnosis of steroid myopathy or not. I couldn't comment on that. But certainly, if we saw an abnormal CPK, it would raise my suspicion that there's some sort of muscular process going on, that this chemical is being released from those muscle cells.
Page 19. So if you'd like to take a minute and look at your note, that would be fine. But I was going to ask you next what your physical examination of Maya upon admission consisted of and what it revealed.
Well, the general examination that was documented by Dr. Rice, Bonnie Rice as a doctorate, was, fairly unremarkable in terms of her heart, her lungs, her abdomen, her general appearance. She was having some distress. Bonnie documented here with any activity at the bedside and was crying and moaning through most of the exam. She was observed rolling from her back to her stomach without assistance, stretching her legs out fully. She would wipe away her tears with her right hand. She became very upset when asked to sit at the edge of the bed. And what else is going on here? She required assistance to get up to sitting at the edge of the bed. She was complaining of generalized pain and a headache. She was oriented to time, place, and person, but refused many activities that Bonnie had suggested to her. Her examination demonstrated some inconsistencies that suggested a psychological component to her current disability. I said she was observed to feed herself cookies independently, but then when asked to grasp an object, she could not demonstrate commensurate strength and started to cry and turn her head away.
I'm going to ask that it be marked as Exhibit 2 to the deposition. Does the history and physical accurately summarize the first encounter that you and Ms. Rice had with Maya on admission to Tampa General?
To the best of my recollection, I don't have anything that would suggest otherwise.
Was there any indication that there were differences in skin temperature on one part of her body as opposed to others?
I don't think that was documented here, so I don't think I could comment on that.
Was there any indication of differences in color in one area of her body as opposed to others?
I don't see anything of that documented. I can, despite the fact that this is quite a few years ago, there was nothing of that nature that I appreciated in any of my examinations of her that I recalled. But I don't recall ever really appreciating any color differences or temperature differences. Those would have been something that would have been documented because that's an abnormal finding.
Were you able to appreciate any areas of alopecia or hair loss?
That I do not recall, and I don't have documentation to suggest that. Nothing that I appreciated significantly enough to document, but I wouldn't venture to say that it couldn't have been present.
After you and Ms. Rice saw Maya and did your initial evaluation of her in terms of the history and the physical examination, did you arrive at some impression about what her diagnosis was and or what the plan of therapy might be?
Well, in terms of the findings and the diagnosis that I could ascribe at the time she appeared she had some weakness, listed in her diagnosis as quadriparesis, meaning weakness of all of her extremities, gait disorder, meaning an inability or an abnormal ability to walk, to ambulate, an impairment of her activities of daily living, things like dressing, bathing, hygiene, and grooming. I don't know that I had anything to actively say that she had muscle inflammation, like abnormal CPKs and things like that. And then possible adrenal insufficiency. Again, this was some information that had been provided to us and that she actually was being treated for. And then pain and anxiety. And I noted that there were some, in addition to whatever else was going on, some psychological component that was reflected in her, degree of distress and the inconsistencies in her performance of activities, depending on if, who was doing it, when it was, how much she wanted to cooperate, or the activity that was presented. That she was, for example, doing things on her own that she couldn't replicate for me when I asked to do them, when she was more consciously thinking about them.
And what was your plan of therapy at that point?
Well, it says here to begin comprehensive rehabilitation, including neuropsychology, integrative medicine, physical and occupational therapy, kind of medical just monitoring and making sure she was medically stable, nursing involvement for safety precautions, and medication administration and education. Social services and case management to help with basically discharge planning and any equipment needs. A dietitian to optimize her nutritional status, getting a hospital homebound teacher to help with school integration, and having the neuropsychiatrist work with her. In general, with rehabilitation, the whole process of admission begins with evaluations by all these different specialists on the multidisciplinary team to assess where a patient is currently. What's their level of function now, physically and emotionally and cognitively? And then moving forward from there, once we identify what their deficits are, then we establish goals to try to work towards those.
Did you entertain any suspicion that this patient had complex regional pain syndrome or reflex sympathetic dystrophy?
I don't recall that being on my diagnosis. That was on my differential or on my radar at that time.
And so my next question was, why would that be?
Why would that not be on my differential?
Yes, sir.
Well, I didn't identify any history or symptoms that I felt were consistent with that. I know it can present in a variety of different ways, but that was not something that seemed to be consistent, at least with the history that was available to me or her physical examination.
Do you recall what this patient's hospital course was?
Well, I had the benefit of reviewing discharge summary yesterday. I went back into the hospital notes just to help refresh myself because it had been a while. But I do recall, without having to look at that this was not an easily predictable course of recovery, and that her performance continued to be variable throughout the stay. So that, again, inconsistencies, I would say, were the most notable thing about her hospital course, and in her response to therapy. Oftentimes, again, every child is different, every underlying problem is different, but it's a little bit easier for me to predict how someone's going to respond to an injury, let's say, if you have a fractured hip, or spinal cord injury, or even a brain injury, that they'd be quite diverse too, but there is a typical kind of course of recovery. Not everyone reads the book, so it's not always like that, and we deal with a lot of people that don't read the book and have atypical courses. But as I recall, her performance varied quite a bit from day to day, depending on the therapist, depending on her mood. I think there was some variability depending on family members being present or not present.
In the discharge summary on the next to last page, I note that there is an indication that the patient should stop taking certain medications, including acetaminophen, clonidine, diazepam, hydrocortisone, and oxycodone. Is that correct?
Yes, but again, the general idea, at least in my approach, is to minimize medications that aren't clearly of benefit. So if some of the medications that were discontinued by the time she had been discharged on the list of stop taking medications is diazepam, which is Valium, which is a sedative and reduces anxiety, but can have negative consequences, sedation, intolerance, and dependence, and addiction, and things like that. So when she came to the hospital, she was 2.5 milligrams every 6 hours, and by the time she left, she was off of that. We also had recommended stopping, Tylenol. That's more of an over-the-counter, though I think that's not really the case because I do start to see Tylenol. So she was allowed to take Tylenol as needed for pain. Maybe we changed the dose. We also had her off steroids. I believe we also had endocrinology see her, if I remember correctly. So when she was admitted to the hospital, she was taking, it looks like hydrocortisone, either 5 or 2.5 milligrams. It might have been on alternating days, but by the time she left, she was taken off that based on the endocrinologist's recommendation. What else? She was also stopped, taken off oxycodone, which is a narcotic pain medication. Obviously can help with pain, but can also have negative consequences. So those were the things that were discontinued. There were several medications that we started that we recommended to be continued after her discharge.
What medications did you continue?
Well, medications that she was not taking when she came in that were recommended when she left were baclofen, which is a medicine for muscle spasticity. It looks like 10 milligrams twice a day. And then she could take an extra 5 milligrams if she needed to 3 times a day for muscle spasms. She was also recommended to take Pepcid, which is something she was admitted on. It's an acid blocker for the stomach. She was recommended to continue with Prozac, fluoxetine, and was recommended by the physiatrist. And then ibuprofen, which is obviously Advil or Motrin, something for pain, a non-steroidal anti-inflammatory.
So was there any by the time of discharge? Had she been weaned off of narcotics and similar medications?
Off both of the narcotics and the Valium, the benzodiazepines, yes.
And what was the discharge diagnosis at this point?
Again, one of the pluses and minuses of an electronic medical record system, this is populated list of problems in the hospital. So that lists the history of steroid-induced myopathy resolved by the time of admission was documented, gait disorder, impairment of daily living and mobility, asthma, psychological factors affecting physical condition, suspected conversion disorder versus factitious disorder versus others, anxiety disorder, and myalgia.
Was there a point in time in which the family or the mother was opposed to discharging Maya?
Well, I do remember a little bit about this, and I recall reading about it at the very end of this day. She was complaining of some headaches, and the mother wanted her to undergo more testing at the time. And I think that maybe vision was a concern about her eye. We actually had an eye doctor, an ophthalmologist, evaluate her. And her neurological exam and her symptoms at that time, I didn't feel warranted further imaging studies of her brain. So we had recommended an outpatient MRI of her brain, but I think that there was a little bit of a holdup. I don't know if I kept her in the hospital an extra day or not, where the mother wanted to keep her some more testing after she'd already undergone, extensive testing, both diagnostic testing, imaging, but also a lot of the clinical testing by all members of the team that were caring for her. But there's
a sentence in here that says, quote, inpatient psychiatric care recommended to mother when we spoke earlier this week, but unfortunately there are no programs near their home, so this was not felt to be feasible, end quote. What was the purpose of that recommendation?
Well, it seemed to me like Maya's mental health was a primary issue that was impeding her progress in functional recovery. And as such, she didn't respond to the type of rehabilitation regimen, or at least she didn't respond as well as I would have liked, by any means, to the type of treatment that we could offer, and I felt like ongoing psychiatric care would be an important component.
Were there recommendations made for outpatient psychological or psychiatric care?
Certainly.
And did you have a specific recommendation in terms of how much or how frequently or from whom that should be gotten?
Well, in terms of how frequently, we recommend intensive, like an inpatient psychiatric program if that were available.
Was there also a recommendation for physical therapy?
I believe so. And given her ongoing limitations, when she left the hospital, she was still requiring a significant amount of assistance. We have here, she wasn't really able to walk. She needed assistance even moving around in bed for the most part. So yes, we recommended ongoing physical therapy after discharge, likely occupational therapy as well.
Was there any point at which you could identify an organic or physiologic reason for her muscle weakness and inability to walk?
I don't think I would defer to the documentation, and if you point me out to something, I can comment on it, but I don't recall identifying a specific physiologic, organic explanation for her functional limitations, no.
I can represent to you, I didn't see one in the chart, that's why I'm asking.
Right. I don't recall having a good explanation that I understood from a physiologic standpoint to explain her functional limitations.
At the time of discharge, did you consider the possibility of chronic regional pain syndrome or reflex sympathetic dystrophy?
I don't believe so.
And why was that?
Again, to the best of my recollection, I don't think I appreciated a history or symptomology that I would attribute to that diagnosis.
Okay.
And she didn't present in a manner, and I know that can be a different type of presentation depending on the individual, but it wasn't consistent with any presentation of CRPS that I'd seen or read about before.
Did you consider referring this patient to a CRPS specialist of any sort?
That was not in the recommendations listed under discharge instructions, and again, without that being something that I considered to be underlying diagnosis, I don't think I would have made a referral of that nature.
Crossed by Mr. Anderson. Dr. Kornborg, I have a timing issue, so counsel has been gracious enough to allow me to do a cross a little earlier. So I'm just going to be here for a little while and then I'm out. And I'm Greg Anderson, and I represent the Kowalski family, and I believe we've got a little bit of updating for you about what happened in this case. I've handed you Exhibit 4, which is an article called The Budapest Criteria for Complex Regional Pain Syndrome, the Diagnostic Challenge. And it's in the Journal of Anesthesiology and Clinical Science Research. And I'm asking you to turn to page 3 of that report. It is not Bates stamped. And the top, there's a listing of the Budapest criteria. Do you see that on table 1?
I do.
And are you familiar with the Budapest criteria for complex regional pain syndrome?
Not specifically, no.
How about the prior 1983 Orlando criteria for complex regional pain syndrome?
I'm not familiar with the name itself. I'm familiar with the symptoms that are listed here in the presentation, but I'm not familiar with them being attributed to the name Orlando or Budapest necessarily.
So you haven't made complex regional pain syndrome a focus of study. Would that be fair to say?
That's true. Yes.
And about how many pediatric patients have you had with complex regional pain syndrome?
Well, I would say probably after completing my residency, and now it's been about 20 years, I would say probably in that time it's been, I said maybe 1 to 2 a year, but I think that's probably more like 15 to 20 patients in the course of 20 years, something like that, overall.
All right, so maybe 1 a year?
Something like that.
And it can be diffuse pain. It can be localized pain. There's a couple of different categories of CRPS, is there not?
I would have to, again, I'm not an expert in CRPS. I would defer to the literature about that. The only time I've been exposed to patients with an underlying problem has been a localized phenomenon, not a general one, not a generalized one. But again, that's just in my experience.
Page 45. Do you treat CRPS kids different when they come in with pain? Somebody who, say, is recovering from a brain injury or recovering from something else?
Oh, certainly.
But in any event, you treat it different?
Yes.
From?
A physiatry point of view.
From a physiatry point of view or physical therapy point of view, I guess?
Sure. And again, it depends on how they're presenting and what their limitations are. I mean, if I have a patient with CRPS that was unable to perform, that was unable to function and to get dressed, then I might use many of the same principles we would use with a patient that had a different type of, let's say, injury to help them regain their independence. With physical therapy and occupational therapy and education, maybe equipment to help them function better, but at the same time trying to control their pain, trying to control the psychological symptoms that you would see with somebody that has severe pain, which is always an issue with people that have chronic pain and things like that.
Sure. And I can provide you with the documentation, the histories of ACH and Lurie's if it's necessary, but I advise you that this muscle weakness that eventually put her into the wheelchair, Maya into the wheelchair, came on very quickly in the space of a week or so. And that began, I think the date is July 3rd or 4th before you saw her. You saw her for the first time on what, July 30th?
Yes.
And at that time, she had already been to 2 different hospitals with concerns about this, right?
That's my understanding, yes.
And the doctors there, I think there were admissions involved, came away with this steroid myopathy related to the drug she was getting for her asthma. Is that right?
That's my understanding.
So when she was presented to you, 2 hospitals had already, the doctors at 2 hospitals, had given you their thoughts of what it could probably be. Is that right?
I'm sorry, what's the question?
The question is, by the time you saw her, or when you first saw her, you had 2 different hospitals that had given you an impression, a working diagnosis, I guess,
right,
of this steroid-induced myopathy, right?
Correct.
And complex regional pain syndrome is a disease that takes a little while to develop, does it not?
Yes, I would say it evolves. There's different stages of it, yes.
And so when you saw her, you were seeing her fairly, if it was, and for this purpose, we'll just say it was, if it was CRPS, you were fairly early into the stages. Would you say that?
I guess if the onset was in the month of July, and then I saw her later at the end of July, then yes, that would be more in the early stages. I would think of the development of something like that.
Page 53. So did she have a decreased range of motion from whatever cause in any of her limbs?
I think I would have to look at the therapy assessments. You know, one of the challenges in caring for Maya during her rehab stay is, again, I mentioned, her inconsistent manifestations and her inconsistent complaints.
Well, then you go down under, and so the symptoms must report at least symptoms in 3 of the 4 categories. Do we have that here, in that she had hyperesthesia, allodynia, and some, from whatever cause, decreased range of motion? If in fact there was a decreased range of motion? I
mean, this is a very concrete, specific question you're asking me. And, unfortunately, there was nothing concrete and clear about Maya. So I'm not sure how to answer that, really. Because, if she had hyperesthesia or allodynia, it should have been something that was reproducible and consistent. But I don't recall anything about her presentation being consistent. I would have loved to have seen something specific like that I would have been able to say, hey, and again, temperature changes and color changes, those are the things that I look for. And the lack of their documentation kind of, I know they weren't there, otherwise I would have documented it. I certainly wouldn't interpret the findings that I recall and the findings that at least I've seen in the recent past and today to allow me to make the diagnosis of CRPS based on these criteria, because I don't think I ever saw a consistent. And that was one of the things, is there were many times I remember that we could do things with Maya and she would tolerate them just fine, and then there were times she wouldn't. So I didn't see a consistent allodynia or hyperesthesia or any recollection of temperature or color asymmetry or any consistency with range of motion limitations.
Page 60. This child had her feet turned in towards each other, did she not?
The documentation does reflect that when she was doing that, but there were times when she wasn't as well. But yes, I know there are. I'm just looking at a note that she would posture her foot into plantar flexion and inversion. Whether that's dystonia versus volitional, I couldn't separate the two. The fact that it wasn't consistent makes me, question whether it really was dystonia or not, but I couldn't exclude that.
Page 62. I'll represent to you, doctor, and this was taken off of a Facebook page. It's been produced to the defendant, and it is Maya under general anesthesia. Do you note there her feet turned in with 2 toes just about touching?
I mean, the picture demonstrates her foot and ankle in that position, yes.
Would that mitigate against this being a volitional thing as opposed to dystonia?
This is a static picture. This doesn't tell me anything about that, really. So there's no way to look at a picture and say this is dystonia or this is a resting posture. Again, I can't interpret this to reveal one versus the other.
Well, if it's a resting posture, that means the child would be relaxed. Are you saying she would relax her feet into that position?
Well, I can't.
With the toes pointed towards each other?
I can't tell if she's relaxed or not relaxed by a photograph. When we sleep, all of us are, and when we're supine and relaxed, all of our feet will tend to go into an equinus position. Now, I don't know the specifics of what her ankle range of motion was at that time. But again, I can't interpret a photograph to reflect dystonia versus gravity versus just positioning. If someone's anesthetized, they're going to be in whatever position they're put in, and then gravity will encourage. So again, it could be dystonia. The only way to know would be to either have electrode sensing or muscle activity. Dystonia means a sustained muscle contraction. And even my patients with dystonia, when they're undergoing, I have patients that I treat for dystonia. When they have to undergo surgery, they're anesthetized and their dystonia is controlled. So I would think that if she was under general anesthesia, whether she had dystonia or not, she should be relaxed. But again, I can't interpret whether her muscle is contracting or forcing her into this position, or if it's just this position she's in based on a photograph. It's the muscle activity piece that doesn't tell us.
For lack of a better term, that level of pigeon-footedness with the two ankles turned to the point where the feet touch each other, that is not a natural position, is it?
But if someone has limited range of motion in their ankles, it certainly could be their natural position. But again, if someone is anesthetized, if they put you in a position that gravity will maintain, then that's the position you're going to be in. And I can't speak to this being, normal versus abnormal. There's a lot of different factors depending on her range of motion, the torsion of her ankles and her tibias.
The issue of her keeping her feet in that position volitionally was an ongoing issue, according to your records here, right?
Right. I think that was a recurrent thing that we saw, frequently.
Right.
And I didn't, again, have an understanding that the note that I just read to you expressed my opinion that it was more likely volitional than dystonia, based on the inconsistency and the fact that she was able to break it and reposition her foot when she was sitting in a wheelchair, and her feet would nicely be on the footrest and things like that. But it was happening on and off. Yes, I do recall that during our hospitalization.
Okay.
And that is a concern because, her examination it was very difficult because of her level of pain and her variability in presentation to try to come up with a great understanding of exactly what was going on.
Well, Jack Kowalski just gave a deposition and described an incident involving whether or not this was dystonia, in which you were working with her and with her ankles, and I guess there was some frustration there, and perhaps in jest or whatever, you had told her, look, you've got to straighten out. Words to the effect that you've got to straighten out these ankles or we're going to have to break your legs and straighten them out ourselves, or words to that effect. Did that ever happen?
I don't think I would ever tell a child I'm going to break their legs. I have said if there was a concern that I think that was documented, and I think her mother had stated about contractures or losing flexibility in your ankles, if you persistently posture any part of your body in a certain position, then you can get stiff in your joints. And again, that could result in a need for surgery to regain flexibility. Typically, it doesn't involve breaking anything. Usually it's a muscle surgery, a tendon surgery, things like that. So no, I would not have said anything about breaking legs. That wouldn't have come out of my mouth.
Page 69. Would you agree with me that under that description there, the Budapest criteria, as taken from this empirical study, I think would be the best way to put it, that under motor trophic, she did have some of the symptoms there. The decreased range of motion, motor dysfunction, weakness, tremor, and we'll just call it in dispute about dystonia.
Like you said, the dystonia, I'm not sure about. I can't comment about trophic changes because I didn't document that. I don't recall seeing them. If they consistently show weakness, then you know they're weak. But my recollection was that Maya's presentation was variable. And there are times that she could do things, and then there are times that she could, and then you'd go to ask her to do something, and then she couldn't do it. And that makes it very hard for me to interpret. Well, what's weak and what's volitional maybe even isn't the right word because I think some people can't do things. I don't think they're necessarily doing it on purpose, but they can't do it for, other psychological reasons or manifestations.
Page 73. And then number 4 is that no other diagnosis can better explain the patient's signs and symptoms. Was there ever, in any of the Tampa General records that you've been through or are familiar with, ever a differential diagnosis made of what exactly Maya had?
I think, the only thing that comes to mind is some of the psychological diagnoses that were documented. And I'm not sure that the psychiatry note and the neuropsychology note suggests. I think in the discharge summary, it comments on a question of conversion disorder or factitious disorder, those types of things, I think could present in that way. I don't think that's necessarily any better explanation than anything else. I don't think there's any way any other organic diagnosis could explain her symptoms. I don't have any organic diagnosis that would manifest so inconsistently where she would be able to do something at one moment and then not the next, or would go limp all of a sudden and then not. So I don't have any other medical diagnoses other than a psychological one that might explain her presentation.
77. Let me rephrase that. As a scientist, which doctors are in part, and also artists in part, would you agree with me that it is at least a possibility that this child had complex regional pain syndrome, developing complex regional pain syndrome?
In my experience, I don't think her symptoms, you're saying is it possible? Gosh, a lot that's possible. I wouldn't say that it's impossible, but I think regional means regional. And I don't think there was any kind of region of her body that I could say that this is where her pain is. It was global, where she seemed to complain. It was her back, her arms, her legs. So at least to my understanding of the syndrome of CRPS, I don't think that her presentation was consistent with that.
Page 82. Nothing in your record indicated any signs of mental child abuse or neglect by the parent, did you?
I don't recall any observation consistent with that. I don't know if there's anything documented that would suggest that, because that would have been brought to my attention and something that we would have had to address. But I don't recall ever seeing anything of that nature, no.
And similarly, in this entire admission, there's no mention by anyone, including neurologists, psychologists, and yourself, of Munchausen by proxy or any fictitious disorder by proxy or anything like that.
I don't recall anything being documented of the nature or discussed during the admission. I know that the mention of factitious disorder by Maya, not by proxy, was a consideration that was documented, but I don't think anybody attributed something to another family member.
And Doctor, I've noted in the take a look at, and here I've got them, I'll mark them as 6. I think we can
Thank you.
Okay. Does this appear that this, Ms. Turtle, does this appear that this was under the care of Marissa Higgins? This date here, August 7th, 2015 at 4:45?
Yes, she's the one who drafted the note.
And through the notes, there were some comments about whether or not the child made more effort with one parent or another parent, right?
I don't know if you're referring, at the very end of the note here it says, patient demonstrates improved participation during today's treatments, but required frequent rest breaks and redirection due to increased pain. Patient was more willing to try standing with mother present in the room.
Does that indicate to you that Maya was willing to try more things with mom there?
That's what the physical therapist thought.
Let me show you what we'll mark as 7, and that's TGH 245 to 248. And this is again with Marissa Higgins.
Okay.
And this looks like physical therapy, or is it occupational? I can't tell. Which is it here?
This is Marissa, so it's physical therapy.
And it looks like it happened August 13th at 4:20 p.m. And under general observations there it says, patient's mother present for a second half of physical therapy. Center of the page.
Where does it say that here? On which page are we on?
The first one, page 244.
Oh, yes, I see. I'm sorry. Yes.
Okay. Says mom present for second half of PT, and then under other, what does it say?
Demonstrated improved motivation when mother was present in the room.
Page 91.
They're flying through. I think we're getting close to being done with Mr. Anderson's questions here.
And in particular, the dystonia, or the talk of the dystonia, and the allodynia, those types of things that you were talking about today, against the backdrop of your familiarity with those things in your specialty. You still believe that the primary issue here with regard to Maya was a psychological or psychiatric or psychogenic feature, correct?
Yeah, that was the most significant manifestation of her symptoms or her clinical issues. There may have been something physiologic or something other than that, but that was the thing that really clouded the assessment of anything else. Because of her tolerance of activities and the variability in the tolerance of her activities and things like that, that I would say was the biggest part that I could identify.
And the variability that you just mentioned and the inconsistencies you talked about today, that was a key issue for you with regard to not being able to identify a physiologic source of Maya's pain, correct?
Sure. I mean, again, it's very challenging when we're trying to help Maya to, let's say, learn to stand and then to walk or to dress herself when we see her performing an activity on her own. And then when we ask her to do the same thing, then she demonstrates that she can't. When we just saw her doing, something very similar. So it makes it very hard to try to help her for whatever reason that may be. And that's why I felt that physiological and that's why I felt that psychological and
Sorry.
Almost got it. So that makes it very hard to try to help her for whatever reason that it may be. And that's why I felt that psychological and psychiatry involvement was very, very important things in trying to improve her condition.
Page 98. And you mentioned the input from the various team members, the interdisciplinary team members. What team members were involved here?
Physical therapy, occupational therapy, psychology, child life, and social services.
And so not only you, doctor, but nobody on any of the other teams that we just talked about suspected or referenced a concern for CRPS, is that right?
Not to my recollection.
On page 11 of your discharge summary, again, it's page 12 on TGA Bates. It's about halfway down, maybe 2/3 of the way down. I'm sorry, maybe 1/3 of the way down. You reference, it says, Maya made significant functional improvements over the period. Do you see that?
Yes.
And so I'll read it. It says, quote, Maya made significant functional improvements over the period when she did not have a rooming in parent, end quote.
Yes.
What's the import or significance of that statement?
Well, I don't want to read too much into this, but I mean, the statement itself would suggest that Maya performed better when her family wasn't around.
Page 103. Would you mind just reading that into the record for us?
It says, quote, she had an episode of symptoms, drooping right eyelid, blurred vision, migraine-type headaches, and that prompted evaluation by a pediatric intensive care unit resident, as well as ophthalmology, close quote.
And if you would, just for my benefit, just read the next two sentences.
Okay, so, quote, neurology aware and did not recommend further diagnostic studies. Symptoms were resolved the following day and for the remainder of the stay. However, on the day of discharge, mother demanded further diagnostic studies, demanding a CT of her head for these persistent, blurry vision and headaches, close quote.
And I lied to you, doctor. One more sentence.
Quote, Maya has not demonstrated nor complained of these symptoms over the past 72 hours, but reported these to mother at the time that she'd been having these, close quote.
And the same question as I asked you before about that first sentence we read on a little bit ago. What's the import or significance of documenting that in this portion of the discharge summary?
The information that was being offered to us, the subjective information about Maya's symptoms was, variable. And she was telling us one thing and telling her mom something different. And so it made, we tried to assess her, the neurologist, the ophthalmologist, and the ICU resident were responding to her, but the report of symptoms was challenging depending on,
I'm sorry, it was changing.
I'm sorry. But the report of symptoms was changing depending on, who she was talking to, things of that sort.
Inconsistencies are significant as far as when you're trying to approach, especially a team approach to treat a patient, correct?
Sure. I mean, just to make a diagnosis, a consistency of symptoms will certainly help us. And that inconsistency makes things a lot cloudier and also raises a lot of questions of, why are these inconsistencies there? And that led to the discussion we had earlier about my concerns for her mental health and the need for psychology and psychiatry to be further involved.
Doctor, I have a note here. It's page 335 of the hospital note, but it's TGH 336, though. Do you have that in front of you?
Yes.
It's a progress note from Dr. Kornberg dated 8/7/15 at 10:42 a.m.
Yes.
Do you have that?
Yes, I have it in front of me.
Doctor, under subjective there, and I won't ask you to read any more, doctor, because it's only about a sentence, but you do, it's documented there, Maya's C/O. And I believe that C/O means complaints of.
Yes.
Maya's complaints of pain have escalated as well since her mother is at bedside. Do you see that?
Yes.
Is there a reason that you would have made reference to that in this particular note?
And I would suspect that this portion of the note was again drafted by Dr. Rice, my nurse practitioner. Just that Maya would, complain more about pain when her mother was present, which, kids will perform differently, where they may focus on a parent, and sometimes that's why we need to have parents away from them in therapy. So they focus on therapy and things like that. But it seems like this would suggest that she would complain more about pain when her mother was present.
Ms. Gross, let me, before you start the next question, are we close to the end, or how much?
Just
because I'm going to need to take a break here very soon, so.
I would say 5 minutes, 10 minutes.
5 to 10 minutes?
Yeah, we're almost done.
Okay. I think we can make 5 or 10 minutes. Go.
We good? Okay. All right, I think your answer continues.
Yeah.
Page 107.
But it seems like that would suggest she would complain more about the pain when her mother was present.
And is that in isolation? Is that something that could be congruent or commensurate with a conversion disorder or a fictitious disorder from your experience?
I don't know that I would link those two. I would just say it's something that's a manifestation of a child and parent relationship. A child is often in this dependent position and the parent is there to help them. So it's not unusual. It's kind of what I was alluding to a second ago, is that when the parents are around, the children may be more focused on the parent, and they may be more likely to voice a complaint than when the parent is present. We see this in other cases, and that's why sometimes we need to keep the parents out of the therapy gym so the kid ends up focusing better and accomplishing more in therapy. So it's not something I would specifically say, at least in my experience, would be, more consistent with any sort of mental health disorder or conversion disorder or factitious disorder, but rather something that we just see in a child-parent relationship.
Fair enough. Would it be fair to say that based upon what you just testified to, that might be one of the reasons why, if you can separate the parent and child, it allows you, as the attending physician or the provider, to test the consistencies and inconsistencies of the patient?
Yes. Sometimes it gives us a better picture of what the patient is capable of, and that's not always the case.
Sure.
But, there are children that won't perform unless the parent is there. But it's something that we deal with often, that kind of the influence of the parent's presence is a positive or a negative, depending on the child.
Page 111. Doctor, let me hearken to your discharge summary once again, and particularly page 11. It's TGA Bates stamp 12 with the discharge summary, page 11. There's a passage near the top of the page, third line down from that says, quote, the neurologist ordered an EMG/nerve conduction study that was normal, of note, despite Maya's inability to tolerate tactile stimulation to her arms and legs throughout her stay. She had absolutely no difficulty tolerating the electrical stimulation and needle insertion into multiple muscles of arms and legs, close paren, end quote. How is that significant? Again, that's another reflection of just the inconsistency in her presentation and her symptoms that were reported. That she could, tolerate something that would, typically be painful, uncomfortable procedure very well, whereas there were times that she couldn't tolerate us, touching her or certain activities with any therapy that wouldn't have been expected to elicit any pain. Okay. So that's just another documentation of that inconsistent presentation. Could you describe for us what a nerve conduction study and EMG consists of? Sure. A nerve conduction study involves putting electrodes, like little stickers, on the skin overlying certain nerves, and then with the device, you can apply an electrical stimulation, so it feels like a shock. And then you can measure through those electrodes the strength, the speed of the signals being sent through the nerves. So that's something that's, it depends on the person. It's not usually intolerable, but it's uncomfortable. And that's one of the parts of the test. Then the EMG, or the electromyography, involves putting needles into the muscles themselves and getting feedback on a screen and auditorily of the electrical activity within those muscles. So that's, as you can imagine, it feels like a needle being put into your arm or your leg or into a muscle. And both of those things are inconsistent with the hyperesthesia? Well, I would think that if somebody had hyperesthesia and hypersensitivity to pain, that, this would be even more painful rather than less, And would tolerating those procedures, the EMG and nerve conduction study, would tolerating them without complaint also be inconsistent with allodynia? It would be. Yes, I would expect, again, heightened pain response with the allodynia with the hyperesthesias rather than tolerating something like that easily. And then the indication here is that there is volitional movement of all four extremities, but performance is highly variable, particularly when asked to move for a medical exam. Is that part of the inconsistency that you've been referring to?
Sure. Similarly, when I saw her, using her hands to do something with her phone or whatever I had, we talked about earlier, and then I asked her to squeeze my hand, and she couldn't demonstrate the strength she was using when she was playing when I asked her to specifically show me that. Just another, again, inconsistency in performance.
And the next sentence of that indicates, and quoting, quote, Maya was functionally worse across all domain with mother present and assisting, end quote. Does that go back once again to the question of Maya not performing as well when mother was present?
That is what that would suggest. Yes, I don't know specifically what Bonnie, Dr. Rice was referring to, but yes, it would suggest that Maya was more dependent and less capable when her mother was present and trying to help her.
Looking at your note of August 7th again.
Sorry.
Page 335, is there a reference in that note as well to Maya's pain complaints escalating since the mother was at bedside?
Yes, it says Maya's complaints of pain have escalated as well since her mother is at bedside. Mom requests oxycodone specifically. Discuss with Mom that it's better to ignore Maya's moaning and only give her analgesics if she asks. We also want to encourage her to take ibuprofen and only resort to the oxycodone for severe pain.
You mentioned earlier that you're fairly conservative with pain medication. If this patient were, you mentioned also that you had a number of patients referred to you with CRPS.
I have, yes. In my experience with CRPS, it's always involved a limb, a single arm or a single leg or, hand or foot or something like that. So there's usually weakness, there's pain, there's often sleep disruption. So there's often an element of a mood disorder, whether it be anxiety because of pain or some degree of depression symptoms or a combination of the two. So pain control and using medication to help improve pain control, I think, is very important. And sometimes I also prescribe medication to help with sleep and pain. And there are some medications that can serve both purposes. And with the pain better controlled and the focus of my treatment approach involves rehabilitation interventions like physical therapy to perform stimulation to the extremity, weight bearing, range of motion, strengthening, using modalities like heat or ice or contrast baths, using electrical stimulation like a TENS unit or something different type of electrical stimulation. So there's a role for medication, but for me, I think the medications play a limited role, and it's really the other interventions with the use of the extremity and the weight bearing that tend to really help those symptoms resolve. But without the medications, sometimes the patient can't tolerate the therapy.
Page 120. So in your experience, is the treatment of CRPS in the pediatric setting a multidisciplinary activity?
Absolutely. And one thing I didn't include in my common recommendations is getting psychology involved, And it's not necessarily, it may be to help address symptoms of anxiety or depression, but it's also to teach the patient and the family methods to try to control pain without medication, non-pharmacologic managements of pain.
Going back to your notes for a moment, looking at your note of August 10th, there seems on page 310 let me just point it to you. Under the physiatry portion of the plan, the first sentence of that.
It says, quote, reports of mom being resistant to medication reduction. Dad states that he had discussions with mom and she is agreeable for now. Limit medical conversations in the room. Steroid wean completed. Further wean off Valium today. We'll discuss the necessity of repeat serum cortisol levels with Dr. Kornberg and continue plan of care. This centers on positive reinforcement, structure, and boundaries. Maya continues to make steady progress with this plan of care.
Page 124. Doctor, we've gone back and forth a lot today, but with everything you saw through this, would you agree that Mom and Dad Kowalski cared about their daughter and were doing everything possible to help her?
I think that requires me to take a step beyond what I'm able to say I know. I can say that I never got the impression in my interactions with the family that they were doing anything to the contrary of that. But I don't think I've had enough exposure to them or know them well enough to say that they were doing everything possible, to help them. Again, but I didn't see anything that would suggest that that was not the case.
So, Doctor, what can we say is you didn't see any indication that these parents were trying to, either one of them, were trying to abuse this child, did you?
I didn't see any. I didn't see any evidence of that in my interactions with them, no.
That would conclude the deposition now.
All right. Acting class is over.
Jury, I think this is a good place for us to stop today.
Gentlemen, we approached just very briefly.
We do it after we let the jury go. Yes. So, members of the jury, do not discuss this case amongst yourselves. Do not do any investigation and receive no information. And we'll see you tomorrow.
Okay, so the jury's leaving for the day. They're probably going to have a little bit of motions here. Let's see what happens. I think it was Mr. Whitney that asked to approach, if I remember correctly. So that was very confusing, especially because we've got people who are changing roles, going from plaintiff to defense. I missed that. There's a comment the jury made as they were leaving.
Okay, the jury's out of our presence if you all want to come up now.
Oh, it's not. I can say it with the guy listening. It was just, I was just looking for a similar instruction to Bonnie Rice about the dates of the TGH admission, just like we did yesterday, so they'd have some, they'd be oriented. And I think Ms. Crawls had the same plan, but that's okay.
Maybe we can publish records.
We can do that first thing tomorrow. Question, are we going to want to do, I know we got the Detective Graham issue. Are we going to do more exhibits tonight? Do you want us to come in, knowing that we're going to go until 6 tomorrow, do you also want to come in at 8:15 tomorrow, or do you want to work tonight?
Judge, well, I would only say that I think the medical records counsel was going to look at tonight to see if there were, as to which ones were not already in, and we wanted to look at that one medical record. I think tomorrow's better, is what I'm saying.
Okay, so tomorrow at 8:15, and then we'll get here at 8:15, we'll do records, and after the jury leaves for the day, we'll keep doing records.
All right, so
and exhibits.
Okay, I'm hearing your honor.
We're trimming the sails.
Okay.
What's the Detective Graham issue?
Did you need to take a break, Your Honor, before we do?
Well, I'm trying to figure out how long this is going to be.
I'm going to guess, I don't know, I'm going to guess it's a 10 to 15 minute argument, but that's just a swag.
Judge needs a break.
What do we have?
They're objecting to Detective Graham.
Oh, so why don't we do the Detective Graham now? I'm just going to stand, because I've been sitting way too long.
Me too.
So,
Your Honor, I think they told us just before lunch that they intend to call Detective Graham tomorrow. We previously filed a motion in limine to exclude her interview altogether for various reasons. At DIN 2531, the court entered an order limiting the use of Detective Graham's interview for really any purpose except for impeachment, which the defense attempted to use with Jack Kowalski. And then the order further stated that if they wanted to offer Detective Graham for any other purpose, they had to specifically seek permission outside the presence of the jury. I can continue in my argument against it, or we can give them an opportunity to.
well, I mean, my order is at DIN 2531. So, I mean, I remember reviewing and listening to Detective Graham, and I think the issue is what they're going to seek to elicit from him. And I mean, I guess these are statements by Jack Kowalski, so we've got an exception to the hearsay, but otherwise it's a hearsay conversation.
Yes, Your Honor. I plan on calling Detective Graham, just briefly walking her through her education and training, and then establishing that she sat down for a conversation with Mr. Kowalski. And during that conversation, I intend to elicit about 6 to 8 statements that he made as admissions by party opponents. I have the audio that I'd also like to play in conjunction with. I'm happy to preview all of those with Your Honor, so you can, before we do it in front of the jury, so that way.
What are the statements that we're talking about?
If I can pull up my outline, I can tell you specifically if you'd like to know that. Almost there, yeah.
In Ms. Crowell's, was there a percent, because it looks like we used about 55 minutes for that. Was there a percentage that you can give me?
I can count the pages and we can divide it up. I think it's usually a minute a page kind of thing.
Well, I mean, is it like 2/3, 1/3, 75%, 25%? Just give me the rough approximate.
Yeah, I'll give you a rough draft. Just give me 1 second. It's highlighted different colors, so I can give you a quick.
Thank you. Mr. Shapiro.
Yeah, I apologize. I don't have the exact transcript with me, but there was a statement about that Mr. Kowalski made where he told Detective Graham he did not think it was in Maya's best interest that Mrs. Kowalski was calling the hospital. The statement that he observed Maya's pain levels to be different depending on who was in the room. The statement about Mrs. Kowalski making inappropriate comments on the phone during supervised calls.
Wait a second, say that one more time.
Yeah, there was a statement that Mrs. Kowalski was talking about inappropriate subjects with Maya during the supervised calls, including talking about the medical care and the lawyers. This might be a little bit easier to do with the transcript, but that's the subject. And then a statement about that if Maya came home, he would have his wife move out. So there's about a half dozen.
If Maya came home, what?
That he would have his wife move out.
We don't believe that those statements are relevant to any pending claim in this lawsuit. The police interview, the detective's interview in the hospital was not part of our negligent infliction claim, which Jack no longer has. It's not part of our intentional infliction claim. It's not part of our medical malpractice claim, our battery claim, or our false imprisonment claim. So it doesn't go to any pending issue in this lawsuit. It's part and parcel of the Chapter 39 proceeding. So we object on all those bases. And 403. Additionally, I don't believe Jack Kowalski representing what Beata Kowalski may or may not have done qualifies as a party admission. And I'll point out additionally that we did have at one time malicious prosecution claim, abusive process claim, and Chapter 39 false reporting, all of which were dismissed on summary judgment. So with those no longer in the case, we don't see how this is relevant.
Your Honor, I know you're looking. Some of this might be easier if I can give you the page lines, because none of this is a mystery. You can actually see what the audio is going to sound like.
Well, the audio is not in evidence, right?
No, and I don't plan on putting the whole audio in evidence, but I can do it either way. I think it is a statement by a party opponent, and I did plan on playing the audio in conjunction with their answer. I'm obviously not going to move the audio in evidence, but I believe I can publish I do believe I can publish the audio and move it into evidence in that regard, yes.
Well, you're not publishing anything unless it's in evidence.
Right, I apologize for the statement. Yes, I do believe we can move the audio into evidence as a statement by a party opponent. Clips of the audio. I do not plan on putting in the 2-hour-plus interview. I was going to select, like I said, somewhere between 5 to 7 clips in total. There was one other one in addition where, and it's very important to our case, where Mr. Kowalski had told Detective Graham that he was in favor of staying at All Children's Hospital after that team meeting that was described, I believe, by Nurse Klink and Dr. Teppa on October 11th, where he says, I was in support of staying. So that would be the other one that I would tend to elicit. I don't know if Your Honor wants to go through each one with page and line. I can have someone try to pull it up, or what your preferences are to do it in the morning.
Anything else, Mr. Whitney?
But it's the stigma of having a police officer come in. So it adds to the veneer.
Additionally, for to appear here on the stand to buttress this argument that Mr. Kowalski was doing something improper.
And we have not excluded yet.
The judge is loving this. He's shaking his head. He's like, they're both arguing. Mr. Anderson's supposed to be telling Mr. Whitney this, then Mr. Whitney repeats it.
Surreptitiously recorded.
Well, here's where I'm at. The statements are statements against interest. They go to issues that remain in the case, and they are relevant. So certainly you're going to be able to call the detective and elicit those statements. We can talk about the clips in the morning, but the plaintiffs will be able to cross-examine as to, whether this was done covertly, not covertly, that she was wearing guns and all of that stuff on cross-examination. But yes, you will be able to elicit those statements.
Okay, that's not
anything else.
It's not very exciting for the plaintiff. That's a big.
We may ask for a proffer because it's going to get very dangerously close to Chapter 39 dependency proceeding territory, and the dependency proceedings are full of party admissions by the hospital, which we haven't been allowed to explore. We think this is part of the Chapter 39 process.
Well, I am confident there's going to be very specific question and answer, page and line, or pieces of the clips that we'll be able to have in isolation, and then we can call it. But generally speaking, what Mr. Shapiro was describing will be allowed as statements against interest, and so it's an exception to the hearsay.
Audio guys working overtime trying to.
Yeah, that's a good question. Does the defense know if Detective Graham or Patrolman Graham will appear in uniform? If so, we'd object.
Oh, no, I don't think she is. She's retired since March of this year. I don't know if she still has uniform. I told her to come dressed professional. Well, I think she's coming in at blouse or something of that nature.
Okay. Anything else?
Okay, the jury has gone home for the day. We're about to go home for the day.
We had additionally the curative instruction I tried to bring up earlier regarding the.
Have it written out.
I'm sorry.
Have it written out, and we can.
It's in our motion. I'm sorry. We'll bring it in tomorrow.
Have it written out.
Will do.
Judge, I'm going to suggest that it was 80% defense and 20%. Are you guys good with that, with Dr. Kohlberg?
80-20, fine.
Yeah.
That's the time allotment of how the time's divided up between the two parties.
Are you planning on playing Matthew Walford tomorrow?
The deposition.
Walford? No, I don't believe so.
Okay.
So for that 15 minutes and 40 minutes?
Yes, sir.
Okay. Is that 80-20?
Let's hear the time.
Try to get out of here a little earlier tomorrow.
We'll do 10 and 45.
Thank you. Appreciate that.
We'll shave that 5 minutes there for you, Mr. Whitney.
We might need it. I was trying to pull the hook on Mr. Anderson several times, so we appreciate the 5 minutes.
No, it was because I did not cross on the second witness.
So that means
shot clock ready.
The timing today, plaintiffs used an hour 40 minutes.
That's too much.
That puts you at 48 hours 15 minutes. Defense used 3 hours 15 minutes, which places you at 22 hours 22 hours 5 minutes. Okay, and what was the next thing, Mr. Anderson?
I was going to try to get out of here early. It's my daughter's 12th birthday, and I haven't seen them in a very long time. So I was just trying to figure out what was going to happen in the afternoon. And was there any chance that Officer Graham can make it earlier? Or are we doomed to after lunch?
I don't know the answer to that. I was playing Dr. Kohlberg. As soon as I leave court, I will call her to see if
I've got a meeting at lunch, so we've got to take lunch tomorrow, but I'm serious. 8:15 tomorrow, and then we're going to go until 6 o'clock. And
Kim, this should be an 8.
We're going to start assessing as to whether we're going to be coming in early, whether we're going to do nights, weekends, but we've got to pick it up. And I know you all need time to prepare, but we made a commitment to this jury as to the last day, and we need to keep that.
One additional issue, if I may. The court pointed out that yesterday we displayed Exhibit 2571, 005 and 2571-004. 005 at the time was not in evidence. I discussed this with defense counsel. It's really just a close-up of 004, but we'd like to move 005 into evidence to clean that up.
Was there any objection to that?
No objection.
So after the 45-second lineup, it's no objection. So what number are we admitting in?
257005.
Okay, the webinar just ended, so we're about to wrap up.
In the wheelchair.
Anything else? Right there.
I'm sorry. No.
Okay, 8:15 tomorrow morning. See you there.
Boom. All right, so now we're done. Now we're finally done. The judge finally gets his break. The jury has gone home. It's time for us to go home as well. Except tonight, Rob on Lawn Lumber has his wrap-up of this, which you're definitely going to want to listen to. There's some great stuff. We want to hear an actual practicing lawyer in this field with experience in this arena explain some of the things that happened today. This is heavy lawyering. This is deep in the weeds. There's a ton of data. I realize a lot of you at various points of this saying this, I'm just confused. It did get very confusing, especially when you have lawyers reading a deposition in. Just for a quick little explanation on how that happens. It can happen for a few reasons. First of all, if a witness is not available, say they die, say they've moved out of the country or have some other conflicting appointment that they can't move, they don't have subpoena power, they're somewhere else. There are a million reasons they could not be able to bring that witness back, but they've conducted a deposition. And the deposition is basically a questioning, just like they're sworn in, just like they are on the witness stand. And both the plaintiff's attorneys and the defense attorneys will question the witness, and they'll make objections and everything else. The judge is not there, but then after the fact, they can rule on that and cut out the parts that were objectionable and cut it down and parse it down to the parts they want to include. And then they have this trimmed down deposition. A lot of times it's filmed, and we've watched a lot of filmed depositions before. In this case, it was a tape recorded deposition, and that was also parsed down. So all they can do is transcribe it into text, and then these two attorneys who want to call this doctor as a witness, Dr. Kornberg, they say, hey, we're going to call the witness by deposition. It's written. It's not videotaped, so we're going to read it into the record. And then they put on their acting hats and they start pretending to be the people who were in the deposition, reading the two parts back and forth. And that's why we had Mr. Shapiro sitting in the witness box and reading from his notes like he was the doctor. And we also had the defense attorney, Corolla. I think it's Corolla is her name, something close to that. I can never get it right. And I don't want to call her Cruella because that's just mean. But we have her pretending to be both the plaintiff's attorneys and the defense attorneys during this. And so she read, sometimes she was reading Mr. Anderson's part. Sometimes she was reading her side's part. And that's once you can get your mind around what's happening there, it makes a little bit more sense. And sometimes you can even detect the voice through the questions. As we've got to know these attorneys a little bit better, you can tell it's Mr. Anderson's voice in the questions from how he words things. So here's what I got. I heard, according to what I heard, the plaintiff has used 1 hour, 40 minutes today. Now, they have 55 hours total, and he's used 1 hour and 40 minutes today, and we've got like 10 days left of trial. Okay, he's used 48 hours and 15 minutes. Okay, that means he's got like six hours and 45 minutes left. 6 hours, 45 minutes. You can't use an hour and 40 minutes every day and only have that much time left. The math doesn't add up, so he has to be very careful. Patty Riddle, welcome to the gallery. Thank you so much. Good to have you here as a member. Thank you. Please take your seat. Exclamation point seat in chat. We've got a reserved seat for you. Patricia Cruels. Man, I'm going to write that down somewhere and then forget it promptly, Amber, as I do. Cruels. I need a pronunciation guide as well. All right. So let's see. What about rebuttal? Okay, so great. You had a great question about the in that deposition, the rebuttal happens, or the cross-examination happens right after the defense went first, and then the plaintiff sort of cross-examines the witness. What about the jurors? The jurors don't really get to ask questions in that case. We did see earlier on in the trial, the judge did allow the jurors to enter questions, sort of, for what? I don't know, because it was a videotaped deposition, but they entered questions and he read them to the jurors, and they just said, okay, just FYI, this is the questions the jurors have in case you want to try to answer that with some other witness. But since then, the judge has not done that. Let's see. It's in mod chat. I'll remember. Okay. Crawlis. Attorney Crawlis. Okay. How many hours did the plaintiff use so far? I missed it. The plaintiff used today 1 hour and 40 minutes for a total of 48 hours and 15 minutes. The defense used today 3 hours and 15 minutes for a total of 22 hours and 5 minutes. Okay. Crowells. Oh, man. I struggle. Okay, tonight, as I was saying, Rob Lawn Lumber, 7 p.m. Thanks, Casey Cat. We've actually linked. If you haven't been to Rob's channel, Lawn Lumber, yet, first of all, you're going to love it. Second of all, I have made a link, so as soon as we close out, if you just sit here and do nothing, just stare at your screen until it goes black after the feed's over, it's going to portal you over to his channel, or at least give a pop-up saying, hey, we're all going, do you want to come with? Now, I realize he's not live right now. It's going to start in like 2 hours, right? But if you click that link and jump over, you can first hit the subscribe button, like the stream while you're there, just to get that out of the way, and then you can click the remind me button. And YouTube will hopefully, fingers crossed, remind you when he starts his live stream, because he's going to go over this and analyze the whole thing, and it should be fantastic because today was an exciting day, all except for that last little red deposition. Where are we with the objection counter? Let me bring that up on screen for you guys just to see where we're at. Let's see. I need... Actually, let me switch this to my screen right here. All right, here we go with the objections. We're at 1,144. If we look at the votes here, Detect Vids had 1,143. So Detect Vids is the closest. Upcoming, if we hit the play button, this is who's coming up next. Maybe this gives you a little better view if it's got a black background, huh? Let's see. Virginia Little says, going on vacation tomorrow for 8 days. I'll miss y'all. Virginia, we'll miss you, but I'm sure it's a well-deserved, well-earned vacation. Take pictures and send them to the burner phone, and then we'll share them with everybody and wish we were there with you as well. So that's where we are with the guesses. And the person who's the closest is going to find themselves the new owner of a Recovery Addict hoodie. Are we telling the chat the stream is over? We're getting close. We're getting really close. I just want to wrap up and make sure we answered every question that you have. Let's see. Anything else? Let's see. What's the highest vote? The highest vote is Infinity, Jennifer. Great question. Below that, I think it's about 14,000. There are 2 5-digit votes, and then the upper end is right in the 3,000s. So most of the votes came in between about 8 or 900 and 3,000. So we'll rewind to where we need to be. Go a little faster. Back. See, the beginning down here was, sorry, it's going fast. 836. And then if we go all the way to the end is Infinity with Jim Bob, and then 17,000, and 13,000, 5,000, 4,000, 3,000. So that gives you an idea. Sorry, I misspoke on that one, but we'll get that back in order where it needs to be. We'll follow that as the trial continues tomorrow. Are we going to have another contest before trial is finished? Michelle, I'm not sure if it's going to be this trial. I would like to do contests a little bit more regularly. I know there are people who participate in the channel and who bring just first of all a great outlook, a great personality, great insight and questions to to the community through chat, but aren't in a position where they could, decide to purchase some merchandise. It's not in the budget. And I would like to at least make it an option or a possibility that some of them could win something. And I'd like to do that on a regular basis. So I am going to try to, hopefully without breaking any rules, because I'm completely new at this, and try to give you options to win some things and make it a little exciting that way. So yes, we want to continue doing that. I don't know how to do it and just need some time to put it together. So if you have some suggestions, send it to me on the burner phone. Obviously, I can't give everything away. I'm also not in that position, so I appreciate that. Ooh, back door is open. What time tomorrow? I think they said, did they say 8:15 tomorrow? So we start at 8? We start at 8 tomorrow. Sorry, Mrs. R.A. She's right here. She wanted to exercise. We already took her room this morning. Virginia wants a sweatshirt that says, strike that. Yes, we've had the...
Scratch all that. Oh, that was terrible. I apologize.
We've used that sound effect quite a bit. Excuse me. Anyway, tonight we're going to go over to Rob's channel and hang out and hear some of his great analysis on this. I appreciate him being willing to do that and also providing just some great insight to us here on our chat. I know he's a busy man working full-time during the day, and for him to be here with us, it was awesome. I'm still grinning from ear to ear. It's just so cool to have him here. The early trial is killing me. I rescue dogs. Sometimes, eventually, we're going to have a trial on the West Coast, and you're going to be like in heaven. So I'm sort of struggling with this Colorado trial because it goes to like 8 p.m. at night. Placeholder is up. Yes, Kim, I've linked to it. So as soon as this live stream ends, it will portal you over there. That would be great. KMET says, who the heck exercises in the courtroom? Well, KMET's contrary to popular belief. I'm actually in my house right here. The backdrop is a green screen, just to not distract away from this, and because we are all true crime addicts, we sort of make it look like we're sort of in the gallery. All right. That being said, Rob says start late. Don, it's worth watching on the replay if the time's not good for you. I realize he works during the day, okay, so he's a busy guy, and then in the evening he's got to go home, get some bite to eat, and then he produces a full video, and it's not like a little video, it's a full video. Anyone who's tried to do that knows that there's a lot to that. There's a lot of moving pieces and parts, and a lot of research and preparation that goes into that, and it's impressive. It really is impressive, and he brings it with his analysis as well. Let's see. No on that question, Mrs. R.A. I do live in the Carolinas. Yes, I'm in North Carolina. Thank you. It's I believe it's heaven. It's perfect. Most, like 11 months out of the year, it's perfect, and the other month it's really bad. All right, I think we're going to wrap it up here. Thank you everybody for being here. A big shout out to all the mods who kept everything so fun in chat. Answered a lot of questions for me. Allowed me to focus on the case, which was really interesting. I told Mrs. R.A. no. She asked a question about what I was planning to do tonight, and I was just telling her. Let's see. I think we might be finding the home for the cat, and it might not be here. We'll keep our fingers crossed on that one. Did you see earlier that someone here in chat related to a lawyer on the Colorado trial? Samantha Terry was asking lots of questions about that. I did not see that. I'll check mod chat to see if that's in there. I think that's it. All right, so tomorrow morning we're going to be at 8 a.m. as our start time. Be here on time if you want a seat. Reserved members obviously have reserved seats, but thank you. Tonight when you go home, please hug the people you love. Smile at someone, make their day just a little bit better, and please stay safe till we go live again. I'll be watching and maybe chatting a little bit in Rob's chat tonight on Law and Lumber. I encourage all of you to join me there. I appreciate that. But then we'll be live tomorrow morning again, as we do this every day, in the Court of Public Opinion. Thank you so much for making this one of the best places to watch true crime on the internet. Thank you, everybody. Be good to each other. We'll see you tomorrow. Bye.
that was terrible. I apologize.